buisana le batho ba transport. Meeting wa rena letšatšing le re na le Honorable MEC Mokgethi mo meeting ke tlo re le yena ke mo fe chance a ti introduce ebe a introduce committee e a tlileng le yona meeting wa rena today.
Hello, re ke leboge chairperson. Nna ka leina ke nna thank you. Nna ka leina ke nna Dr. Nomathemba Mokgethi, ke nna MEC wa healthy or tsa maphelo mo Gauteng. Ke tsamaya le HOD le CFO le ba bang ba tla dumela ba introduce. Ke a leboha. HOD.
And the senior core management, Yago departmenting, they're all sitting on the right side of the hall. If they can just lift their hands. Thank you. Thank you, MEC. Thank you, Chair.
Dumelang, le kae? Re gona. Lebitso la ka ke Lerato Maggio, CFO ya department, thank you.
Dumelang, honorable members, le community, lebitso la ka ke Tshulofelo, at Telecon, ke responsible for planning in the department.
Dumelang community at Atteridgeville, ke Motalata Mudiba, Chief Director Communication in the Department of Health.
Rishile, my name is Basani Baloi, DDG Corporate Services.
Dumelang bagolo, lina la ka ke Mpho Melale, ko budget office. Thank you.
Dumelang bagaetsho, nna ke na Freddy Khongwana, the acting DDG Hospital Services mo Gauteng Health. Thanks.
Dumelang, lebitso ke Nnoke Ragwale, District Health Services.
Thobela bagolo le botlhe community at Atteridgeville, ka leina ke Canada Masaneng, acting Chief Risk Officer ya department.
Madume, Montodi Butani, budget office.
Sanibonani, igama lami nguThokozani Okalanga. Ngisebenza nge-stakeholder engagements and intergovernmental relations. Thank you.
Locha, this is Sandani Kobo, Wazifato, Nda.
Ndi macheroni batho botlhe ke Mogadira Sebetšhele Forensic Medical Services.
Dumelang, ke Ruben Reiters wa EMS.
Thobela, ke Lesibo Malotana, I'm the Chief Operations Officer.
Ke a le dumedisa, ka lebitso ke Mokete wa Motaung, ke nna CEO ko Vescopis Hospital.
Locha, ndi abafana musiye CEO wa Odi Hospital.
Rali dumedisa ke Dr. Sello Machila, the CEO wa Kalafong Hospital.
Dumelang, I'm Duduzile Mthethwa, CEO for Jubilee Hospital.
The Macheroni, Nemokoma Mekatu I'm the area manager in Tshwane, sub-district 2, 3 and 4.
Dumelang, ke Modise Makhudu, Primary Health Care mo Tshwane.
Re a leboha ke nahana hore re bone hore Department of Health e tlile le bo mang ba ba tsamayang le MEC le rena re tlile le bo mang ba ba tsamayang le rena as honorable members of the Gauteng Legislature. Mahareng ha rena le councillora me Esther Masuku kupela o eme o dumedise setjhaba sa Atteridgeville le sa Gauteng se se tlileng. Ke o kae Isaac? I notice that thing. Bring it here, it's fine. Ira dumedise ke me Esther.
Dumelang badudi ba Atteridgeville. Le teng? Okay.
Rena hape le councillor Pasha ke councillor wa mo Atteridgeville Ward 71 le wena ino yema o ivele setjhaba se o bone. Ba bang ba tla re joina ge nako e ya, I'm sure ba tshwarehile. Rena le other councillors ba senke ba fihlile re tla le bontsha le ba tsebeng. Re a leboga. Re ke tšee nako e ke le amoheleng ba bohle mo meeting wa rena. You are all welcome to this meeting. Lebaka la hore re be le meeting o today, re tlo bolela ka di APP. Wa bona enkebe le tshwere dilo tse be di tlo le thusa gore APP ke eng. Nna ke tla e bala ka sekgowa o le di tshwere le sharp. Re tlo theeletsa di APP le budget vote 4 ya Department of Health ya Gauteng gore di bapladile eng go thusa setjhaba sa Gauteng. Sa boraro se re tlo se bale sona ke gore re ile ra romela dipotšišo, di questions to the department, so le tsona ba tla re fa dikarabo tsa di questions tseo. So re tla ba le presentation ya mathomo ke ya di APP, ya bobedi ke budget vote 4, sa boraro ke di questions. So re tlo tšea di karolo tse 1, 2, 3 ka nako e 1. From there re tlo tla go lena setšhaba gore le kgone go botšiša dipotšišo mabapi le budget vote 4, mabapi le di APP tša Department of Health le di questions tse ba tla beng ba di arabile. So ne ke tlo kgopela gore MEC o le mo kgethileng gore yena o tla tla mo a tlo starta go bala di APP e latele ke budget vote 4 le di questions. Ke le fa chance.
Thank you very much. The CFO will present the budget vote for, and Sulu will present the APP. Agera utlwana batho ba bagolo. Ke re CFO o tla present the budget vote for, then tse ding tse chairperson a di buletseng tsa di response to questions le APP di tla presentiwa ke Metsulu Adelekan. A ke re mone wila I introduce someone. Ke a leboga.
Thobela. Dumela, I'm not, okay, thank you. Ke a leboha. I'm hoping that there will be someone at Artusangao flight presentation. Based on the, I'm hoping, Chairperson, that it will be fine if I present in English and use my vernacular language as and when I do the presentation. Ke a leboha. Okay, based on the presentation Eri submitting, as you can see on the screens, we are talking to budget vote, department as vote for the year that has started on the 1st of April 2022 and that will end ka di 31 tsa March next year. So based on the budget, Renale table of content that speaks to a strategic overview sa department, and then also a preamble that will then talk to the organizational responsibilities, and then again re bolela ka 2021 MTEF reduction baseline. So here we are making a presentation of how budget cut the previous year is affecting this year and the 2 years tse di latelang in the 3-year rolling budget cycle. And then again, we are going to give an overview, 2022 budget, compare 2021 as to where are we coming from in terms of the budget allocation of the department and where are we today with what has been allocated. Then re tlo bolela ka the assumptions tsa hore why has National Treasury through the Provincial Treasury allocated tšhelete e ba re fileng yona for the year 2022. And then re bolela ka 2022-23 alignment le GDT. Hele hopola the Premier made commitments tsa hore Gauteng ina le growth targets tse re nyakang ho di achieve for 2020 up to 2030. So rena as Department of Health rena le di targets tse ba re fileng tsona as the priority. Hore what then do we need to achieve by the year 2030 as part of our responsibilities Department of Health. And then Robola 2022-23 earmarked allocation and then allocative efficiencies more programming. And then Renale annexure APP present my colleague Tsolo, and then lead the question and answers based on meeting on a otwere Khalekwa. So level preamble ya rena re mo Gauteng renale population e kana ka 15.1 million people bannang mo Gauteng, and this now constitutes at least 26% of the overall population in South Africa. Mara ha o lebella population growth, we're talking to plus minus 0.3% increase from 2020. So renale an increase 0.3% compared to batho ba ne batla ba nna mo Gauteng. Remember, Gauteng is the economic hub South Africa. So people will always come to Gauteng to look for jobs, to look for better lives, whether they come from different provinces or they come from different countries like Zimbabwe, Mozambique and the likes. Everybody wants to come to Gauteng to earn a better living. So if we look into population growth, 2020, we're now talking 0.3% increase. And then her level more 15 million 80% ya batho ba bannang mo Gauteng ke batho ba ileng hore a bana di medical aid, and they depend on government for provision of healthcare services. And then again rena le batho ba kana ka 4 million or so, let me say more than 4 million ba ileng hore some of them have gone for testing HIV and AIDS program and some tested positive. So Gauteng Health is now responsible for treating those patients in terms of HIV and AIDS program. And then Renali clinic they operate for 24 hours, although re enter into different phases. Ka phase 1, Renali a certain number of clinics that operate for 24 hours, and then phase 2 is also going to be looked into in terms of clinics that are operating 24 hours. Not all our clinics operate 24 hours, but per district they operate 24 hours. And then relevant happily issue the quality of health care re providang mo Gauteng re targetile hore e improve above 90% her level the primary health care services, and ke tsona di clinic tse leng hore many of us start at before we are ko dipetleleng tse kgolo. Again, on EPWP program, re comply le legislation e bolelang gore re review the program, refer the job opportunities to our youth that are below 35 years of age. And this program le yona tšhelete ya teng e ka mogara yona budget e re tla beng re bolela ka yona ka jeno. Of the whole budget ya Gauteng, re na le 59.4 billion e ba re fileng yona for the year 2022-23. Re increase it from 56 billion year last year, and this year we are now talking 59.4 billion. The next slide, like a vision statement. I'm not sure who is controlling. Okay. Okay, thank you. The next slide, like the vision statement and the mission statement, lead the values tsa rona as Gauteng Department of Health. Our vision is to have a responsive, value-based and people-centered healthcare system mo Gauteng. And then mission wa rona go transform or go change our healthcare system to improve the quality, safety and coverage of health services provided, focusing on primary health care, strengthening public health education and health promotion, and also ensuring a responsive, innovative and digital enabled health system. Our values, of course, will include humane, efficiency, accountability, loyalty, transparency, honesty and innovation. So that is now the vision and mission statement of the department. Here lebella di priority. Priority number 1 ya rena ke ho improve NHI. So NHI e bolela ka National Health Insurance. Mo e leng hore plan ya rona is to achieve UHS. I'm trying to speak it in my lingo.
Okay.
I get to Rukastana by Bizang, but universal health coverage. I get to get Talusabang, Mara, Baba Holubata Talusa, Habara Diput. So, our intention in terms of national health insurance is to ensure that at least there's universal health that is provided to our population in terms of the quality of health, and they can't afford to have the medical aid and attend to private healthcare sector. So intentional, at least majority of our South Africans must then be covered by the NHI program. And then one of our priorities again is to improve patient experience care. So when you go to the clinic or you go to a hospital, our plan is to then say what you experienced in the past must not be the same as what you are experiencing now. So we are improving the quality of healthcare services. Remember, it's a priority. It's something that we are aiming to do and we are improving as time goes by. So another key priority is to improve clinical services, which then speaks to maternal, neonatal, infant and child mortality reduced. So the rate at which our newborn babies are passing on at our hospital has to reduce. So the plan in terms of the strategy is to ensure that at least this quality healthcare services are provided so that we don't have too many babies who are born I don't know how to explain it, but prematurely, or either they pass on whilst they are in the process of being born. Another issue is to strengthen public health, literacy and health promotion. This now speaks to educating our people on how to take care of themselves, the type of food they need to eat, how to look after themselves when they are sick. And then economic empowerment and job creation will now talk to job opportunities that we want to create and giving people business opportunities within Department of Health. The last item in terms of our priorities is to strengthen governance and leadership. So here are issues of governance. We are saying we need to now ensure that we are not a department that is seen to be promoting irregularities when it comes to tender administration and also giving businesses. So issues of governance or maladministration within the department. But again, strengthening leadership is that we're placing people in strategic position who are capable of doing or leading the organization. And based on the next slide, ke mo ke boletseng ka issue ya di budget cut. He ngwaga wa 2021 no thoma provincial treasury e fokoditse budget ya rona ka 6.1 billion. Ka ngwaga wa 2022-23 budget ya rona e fokotsegile ka 8.6 billion. And then 22-23, that is ngwaga o latelang, we are going to experience another budget cut ya 6.7 billion. Mara he re lebella 2022 mo ba fokoditseng tšhelete ke issue ya di salary. Aras government ha isa khona go afforda go increase the salary tsa di employee. So instead of us giving them 5% of your minimum salary, we are only giving 1.5% of the minimum salary. So here lebella batho ba 80,000 and odd being employed under health. We now find ourselves being in a situation where we can only freeze a salary increase to 1.5%, and the money there too amounts to 6.845568 billion. Another budget reduction speaks to medical supplies, where we are now seeing a reduction of 279 million. The laboratory services, where you go and do your laboratory test, whether you're having TB or there's blood test or whatever that is done, there's 159 million that is reduced. On medicine, in terms of the drugs or medication that we receive, we are now talking to 269 million budget reduction. So all in all, 8.6 billion in terms of the budget allocation for the year. On the next slide, we're just giving a high-level presentation on all our programs. More health, we've got 8 programs, which starts ka program 1, administration, and ends ka health facility management. So on these programs, budget program 1 is 1.4 billion, and then majority ya chelete it's our program 2, program 4, le program 5. Program 2 in a budget ya 20 billion, program 4 in a budget ya 10.9 billion, and program 5 in a budget ya 21 billion. So if you look into the allocation, mainly these programs take the bigger chunk of the budget that amounts to 59.4 billion. Here level program 1 in the main, Kiona to implement a project there, health information system. So we improve our technology, how we are clinicking or hospital. Your file can then be in the electronic system instead of a manual file that you will now carry. So the main program, program 1, is to then facilitate or ensure that we are improving all health information system to ensure that information in terms of records is now kept electronic instead of manual. On program 2, increase LinkedIn speaks to the district healthcare. So here level district healthcare, we're talking to plus minus 20 billion that is allocated for this program. EMS in Ali Kimoba Dilanka the ambulance that are transporting you, whether it's the helicopters or the road travel EMS, we're now talking to 1.6 billion allocated to the ambulance. So we will be buying more ambulances. In fact, we bought last year, and we are continuing to increase so that we speed up patient call response in terms of availability of the ambulances. Provincial hospitals, that is now program 4. Kimo ilong hore renale budget ya rona program 4 and 5 kimo ilong hore renale chelete ya COVID-19. As we all know, COVID-19 is a new pandemic that has now come into South Africa around the year 2020. So hene COVID ifitla, we had to employ more nurses and more doctors, including more administrators, to assist ka program ya vaccine rollout. So chelete elimmo in the main ibulela ka chelete ya vaccine rollout. I think for this year, renale plus minus 1.1 billion ever filling yona for employment of not permanent employment but temporary employment, our clinicians and also administrative support. Over and above that, renale 447 million elong hore re tlo berekisa ho reka ditlhare, ho reka dilo tsa vaccine, so that and to also ensure that we put vaccine sites and people can then go for their vaccine injections. So program 6, health science and training, kimo ilong hore re allocate budget for provisioning of bursaries to our nursing students and also provisioning of bursaries for our clinicians and administrative staff to then be continuously trained on healthcare provisioning. So program 7, healthcare support, is now talking to mainly medical gas. When we are in hospitals, we've got people who are admitted who would now require medical gas whilst they are admitted. So in the main, under program 7, kimo ilong renale yona chelete e rebelling for provisioning of medical gas. Program 8, kimo re bolelang infrastructure. More infrastructure, kimo re rang maintenance ya dipetlele tsa rena, and where we now build new infrastructure and also refurbish our hospitals. So the money there too is now 2.4 billion. On the next slide, it's just the same presentation, mara ke mo re breakang down byanong gore mo di salary, how much are we paying to our employees and how much have we budgeted for? For the salary, we budgeted 35.2 billion. For goods and services, where we buy ordinary resources required, transportation of patients, and HIV/AIDS program, ke mo e leng gore re beile 19.5 billion. Transfers and subsidies, these are now transfers tse re di etsang ko di non-profit organizations tsa rona, o tshwana le bo Nelson Mandela Children's Hospital. So we are talking to 1.7 billion and leading municipal clinics, mo e leng gore re ba supply ka medicine and also give them money for them to do door-to-door HIV programs. So there's also money that we've put in here for employees who will be taking retirement. As we know, we've got our clinical staff and admin staff who are retiring as and when they age. How if it's age 63, age 65, you then take your package. So there's money that is now allocated for those kind of retirement packages. Again, re patela di medical legal cases. Tse leng gore, at times when we are being charged as government for legal cases, we then have to make provision for the court cases. Sometimes it's an error that a doctor does when they operate a patient, and then government is sued, so we pay those monies under transfers and subsidies. Again, payment of capital asset, I spoke about buildings where we are now constructing new hospitals and clinics, like Mandisa Shiteka around Tshwane, that is now the new clinic that has been built. And then machinery and equipment is where we buy hospitals equipment like health technology equipment and also computers for administrative staff. I'm not sure, Chairperson, if I should continue talking to the alignment of GGT intervention in terms of 2022-23.
Thank you very much, Chair. Thank you very much, CFO, for that presentation. I think the next presentation will be the so we will receive the presentation about the APPs now.
Yeah. So, relevant presentation, CFO, litotse a booklet, klankana eso, right? So everything as CFO and I present is in here. So, okhona bona gore tšhelete re filweng the 59 billion e berekisetswa eng. So, re tsentse hape le di pictures to show gore for EMS, how fonela EMS, o batla EMS tlo lata ko ntlong, how much money are we spending ko EMS. Ko number 1 kwa e go bontsha gore ICT, which is I mean halitla ko di facility ha le batla o ema sebaka akere. So we're going to be automating the system tsa rena so that when you come into our facilities, your record tebe already in the computer. So already ra go bontsha gore tlo spenda bokae also on that, and ra le bontsha hape gore tlo spenda bokae ko dipetleleng tsa rena gore le kgono ke ra ditlhare and all those kind of things. So please do go through it, and ka mo morago kgono bona hape le all the priorities that we're going to focus on for this particular financial year. Ra leboga. So ke tlo present the APP. If I can ask, okay, the other presentation, not the budget vote. What's the APP? Sorry, ma. Okay, it's APP ya rena ke plan ya rona ya 5 years. Akere ha mokgatlo every 5 years mokgatlo o tla go lena o tlo le botsa gore what do you need as communities. Le bolela mokgatlo gore na community we need this and that, and then mokgatlo unka all those things, body kopanta, body fa government. And then we as government now has to translate policy eo ya mokhatlo. Really as government, ka tšhelete e CFO and bolela ka yona the 59 million. Re tlo e berekisa for go make sure gore bo mama le bana le di services bontate bana le di services. So ntwe ke tlo presentang gona ya no ke yona plan eo e bontshang gore tšhelete otlhe re kry-ileng the 59 billion e re kry-ileng it's for you. Why? Because our vision as health go go ba responsive to your needs. And this is the whole idea. We were established as a health care department because we need to make sure that you are able to obtain the care and that care must be of quality. As a department again, we need to comply to. And the international commitments, the SDG, which are, internationally based, because as a country, South Africa, has a relationship with many other countries. So we are signatories to conventions, other countries within the UN body. And that is why as health, now and then, Minister Arena, MEC Arena, bakopana le other countries, who bolela gore rona as a country, as a province, with the money that we got, rents and kayon. The other important thing that you need to know, ultimately we need to make sure that it's not just about quantity. It's not about we've seen this many patients or we've provided care to this many people. It's also about quality. And you will see as I present all those commitments that we will make sure you get quality of, health care. We also have, over and above the policy directives, they are in the MTSF framework. MTSF framework is a policy direction in government. Renali, that 5-year plan, and out of the 5-year plan, in 5 years, so I can skip because today, so I'll go directly to the slide. So here it's about the vision, and CFO has gone through it, and I'm again reiterating the fact that we want to be responsive. We want to be able to respond to your healthcare needs as a department, and there are multiple programs that we're going to be implementing to make sure that we become responsive to your healthcare needs. So I'm going to skip this slides. Then 5 years. I'm just going to focus on slides this year. This year, what is it that you can expect from us? And you as our community, you are a partner to healthcare delivery, so you can also ask. If you see that we're not fulfilling that commitment, you have the right to ask what happened to this particular area. So in your households, on a monthly basis, you have a budget. Or this money kya groza, ena kya skolo, ena kya miriri, ena kya, manala and all that. The same way, that's how the department works. When we get that 59 billion, we need to categorize, we put it into categories. We say, ena kya who make sure the department runs. And this is where you'll have what we call program 1, which is administration, that has all the human resources, because we are a human resource intense department. There's no healthcare without the people. There's no healthcare without the very nurses, the very doctors, the very porters that have to push, patients. So within that particular area, we're saying as a department, we're going to be making sure that we've got a proper structure, a human resource structure that will enable us to be able to deliver that care. And again, another important aspect that we're going to be focusing on is the decentralization of the administrative processes. Why decentralization? We want care to be provided closer to where people live. And we want all the support services to be closer to support the delivery of care where people, live. And we want to also automate our business processes so that there's efficiencies in the way we render, services. And this is where the digitization program comes in. We value not only yourselves as our clients, but we also value the people that offer care to you. And this is why we'll be continuing with what we call employee value proposition program. So we've got targets, just like when you are a student, you're saying in 5 years' time, I want to be, or 6 years' time, I want to be a medical doctor, or I want to be a teacher. The same way our plans work. That's how our plan works. Really, by end of this financial year, in terms of administration, we will make sure in terms of occupational health, we'll make sure that all our facilities, by end of the term, are compliant to occupational health and safety. That they've got, doors telling when there's fire, but or the exits they are marked. Those are things that are found in this occupational health or molao legislation here, occupational health and safety. So we are working together with infrastructure to make sure gore ra checka dipetlele tsa rona le ditleliniki tsa rena mo go senang di fire hydrants ga gona le mollo. There should be water e leng gore e tsologela mo those places in gore building discadiacha, and that's what we're going to be making sure that our facilities are compliant not only to the administrative components of the legislation but also to the infrastructure aspect. We don't want you, when you come to our facilities, to wait too long. Be it how to retrieve a record or house no fewer, pampitana area or pharmacy, we don't want you to wait too long, and that is why we're going to be increasing the facilities. You had a number of complaints about. We're going to be making sure that those facilities become what we call lean. So they implement the lean management system so that when you come in, you can be served, timeously, and you don't have to spend a lot of time. We've had challenges in the past where we've seen lawyers, litigation, the lawyers, they come into the system, and it's supposed to be used to render care for the litigation. So as a department, we're working together with we're working together with the law society, we're working together also with other government departments and other private sectors to make sure quality, the healthcare services here improve, and at the same time, as a department, we do acknowledge and we do take care of, through mediation, of those particular problems. So with that, we aim to make sure by end of this financial year, we've reduced litigations to 15.5 billion. The other issue we need to do as part of improving governance and leadership in the department is to give you assurance that whatever that we do as government officials, as our leadership, that is according to law. And we invite the Auditor General to come and look at our books to check what is it that we have done with the money that was given to us. So Auditor General then gives an opinion of our books. And I can proudly say that Auditor General has previous year found that our books are, they don't have material findings on our books, meaning our books are close to very clean, if I may put it that way. So there's nothing major, it's wrong. And by this year, and in the outer years, we're expecting to have a clean audit. So we want our books to be free from material findings. We don't want to be found wanting, basically, by these external agencies. The other issue that we're planning for this year with the money that we've been given is to make sure the pampiri the records. Sometimes you come to our hospitals and clinics and we sometimes struggle to get that paper record. So we are using this money to automate. So we're digitizing your records, meaning pampiri ele now is going electronic form, and with the HRS system, health information system, that we're going to be implementing across all our facilities, both clinics and hospitals, with young children or people that are doing their records for the first time, it will be completely, an electronic record. Okay. The other issue is before you used to go to our facilities, PACS basically is those X-ray pictures. So you get an envelope and the X-ray pictures. With this money that we're getting, we will make sure for labor doctor, they don't struggle. If we refer to from, Lodium, we are positive, Biko, we are Kalafong, Doctor Kalafong already would be having X-ray how on the computer. So you won't have to stay long, already really ready to attend to whatever complaint that you'll be coming with. So we want all our facilities to have PACS. There are some adjustments, of course, that will be made on PACS for the CHCs, because for this year, instead of all CHCs, we are going to focus on 18 of the 36. Why? Because the facilities for them to have PACS, they need to have radiology equipment first. We're going to also for forensic, so our department caters for birth to death. We cater also for with dignity. We're going to be implementing again a forensic pathology management information system so that we can also be held accountable for the deceased family, members. Are we making sure that they are attended to, timeously. Within administration, again, we intend to improve our spending of, in townships. So we are through the database here, National Treasury, intending to make sure that 30% of the budget, goods and services, CFO and I presented that at least that the negotiable part of it can then be used to empower Abatu in the communities. So do register in that database as a supplier if you have certain competencies, and do commit then to provide, quality service. We also intend to make sure for at least 80% of our invoices are paid within 30 days. This must be invoices and all the documents were submitted, because a lot of time a service is provided, maybe but because by the time it's provided, all the papers are not there. We are not able to pay. So we wish to encourage people. If we need that tax certificate, please include it. If we need your invoice, please submit it on time so that we are able to pay you on time. So 80% of those invoices, we commit to pay them on time. We also commit to empower Bomme, such that 49% of the SMS arena or senior management, the occupy Bomme. So this encourages again our young girls, young women to aspire to improve themselves, so that Bakira such, opportunities. Now, we're going to be spending around 20 billion for district health services. And this is where we're going to be making sure we attend to primary prevention of the diseases. We don't want people to be sick as a department. We want to prevent diseases. So we will be, implementing various health education programs, health literacy programs that can then, improve the health awareness, Lona as, a community. We're also going to continue partnering with the NGOs so that, care can be provided, closer to where you are. We intend again to expand the number of clinics. Like if sites they don't have clinics that are operating within 24 hours, and maybe you are not able to go to that facility, we intend to increase the opening times, so that even when you knock off from work and you need health care, you can just go to those particular CHCs. We also value feedback Lona as communities, and that is why every year we implement surveys, and these are patient experience satisfaction surveys. We give you an opportunity to tell us, how do you see our service? Right? So we encourage you again to participate in this kind of services, because with your feedback, we can then improve areas that are of concern. And I can proudly say that before we have gotten some
areas that you were not happy about, and we are working hard to address those. So we are aiming to get at least, from those surveys, 95% of the responses, there must be positive responses, meaning we want to be able to address all the other areas of concerns. In terms of severity assessment codes, we are going to be making sure that our hospitals, our clinics, if there are incidents you've reported or they happen within the facility, that are very extremely serious, the leadership needs to be aware of them within 24 hours. So we will be making sure all facilities, at least 95.3% of those facilities do report these severe incidents, and we'll also be tracking whether there was any intervention in terms of those incidents. And this is why we'll be making sure that at least 92% of the incidents are closed, are on time. We want you to come to our clinics and find that everything is fine, that there is all equipment, all medicines, immunizations if you are bringing your children for immunization. And this is why we assess our facilities, and we want at least 90.5% of our clinics to be accredited as ideal, so that you have confidence when you come to our clinics. We also value partnership, as I said earlier, and it's for this reason that we will be ensuring all our facilities, all our clinics have clinic committees. And if you don't feel comfortable talking to a healthcare person, you have a community representative that reports directly to the MEC if there are problems. And hospitals will have what we call hospital boards. We want them to be functional so that on a monthly, quarterly basis, they are able to pick up what communities are saying, what the hospital is saying. We also intend to make sure that if you have a complaint, that we as a health care department, we are able to resolve those complaints, 95% of them within 25 working days. We intend again to increase community healthcare centers that offer 24-hour services to 38. In terms of district hospitals, what is very critical, not only in this province, in this country, but globally, is the health of women and children, because these are the vulnerable categories, again, of our societies. We don't want any woman to die during childbirth, and that is why we implement a number of interventions to make sure that fewer women die during childbirth, or fewer women die even postpartum or after childbirth. That is why we encourage you as moms, as women, as dads, and bogogo, that if a woman has delivered, please encourage them to go back to the clinic or the health facility within 6 days, so that we can also check if there's nothing that is going amiss. So it's very important that we focus on that as a department, and that is why we're planning for that. Again, in terms of malnutrition, we don't want any child to be deprived. So we want children to attain their optimal growth spurts, and that is why we want, we prevent basically chronic malnutrition, or what we call severe malnutrition. We don't want any child to die because there wasn't food within home. Government has social development. We as health sector, we can also refer you to those particular, I'm gonna try and skip some that are also in other areas. Mental health is another area that is important, so we'll be increasing the number of mental health care beds in our province. With regards to our programs, we are going to continue with implementation of HIV programs. And one of the key things that we want to reach, we want you, at least 90% of people in any area to know about their status. And that is why we continue to encourage you to please test. If you've never tested, go test. It's a free service that we offer. So the money that CFO was talking about is exactly for that. Testing, and once you've tested and you are found to be positive, there is treatment, available for you. So that treatment, the money that is given again is for that particular treatment. There is also a marquee outside. We've set up a place for not only COVID, but also for, HIV testing. So please do, and TB and all other services, diabetes, please go outside and get those particular free services. So the money that was just shown to you is there for these kind of services. I want to also, and vaccination, thanks HOD. The other issue that I want to reiterate is that we've got people, even in Atteridgeville, that we've placed on treatment. But what we found is that sometimes the addresses that are given are wrong addresses. So we ask even our leaders, our community leaders, councillors, to help us to make sure that when children or families are placed on treatment, please let's encourage them to give correct addresses. If correct addresses are given, we can send our community health workers to go and provide support. And that is what we are planning, for, as well. We've had challenges with child retention in care. Why? Because sometimes caregivers don't bring these children to our facilities. We also urge our communities and our community leaders that let's work together to make sure that at least 90% of these children that are placed on treatment, they also virally suppressed, meaning they take treatment so that their viral load can, reduce. So it's something that we need to get to do in partnership with yourselves to be able to, succeed. The same thing with TB. We need to also make sure that not only correct addresses are given, but if there is difficulty in terms of taking the TB treatment, do reach out to the community health workers, do reach out to health workers so that we can then reduce this particular loss to follow up. So our programs, particularly for HAS and mother and child, they are rendered across all our clinics. Another key issue, we offer reproductive health services and we're planning for it. So there are contraceptives in our clinics that are free. Please do access them so that we can also improve these particular targets. Let's make sure also that when you don't see your period, please do go to the facility so that we can attend to you on time, because a lot of mothers that die during childbirth are mothers or women that were not attending antenatal care, or mothers that came very late to our facility. So please make use of this particular service. So I'm going to be rushing because of time. The other issue that we've seen, that we've planned for, is little babies that die within 0 to 6 days, of birth. It's very important, again, that mothers attend antenatal care and do come to our facilities 6 days post-delivery so that you are able to obtain the necessary care. No problem.
Ba batlileng after ba ba re joinileng go na le di earphone le di kreyeng gore le khone ho tsamaya le yena ha bolela, because go na le di translation ya mathomo. Number 1 ke English, 2 ke Afrikaans, 3 ke Sepedi le Setswana, and then 5 ke Sizulu le Sindebele, and then 6 ke Tshivenda le Xitsonga. Emisa matsoho hore ba le fe di earphone gore le khone ho tsamaishana le yena ge a ifa presentation ebile re a leboga gore le tlile re tla emanyana go fitlhela ba lefa le kgone go connecta please can you assist in distributing the mic or the earphones to our stakeholder so that they are able to hear it. Tshwara. Serame. Tse ding a se. Tshwara. O ka no nwa metsi mema. Hello bolela. Ba rena ba tlile a go tshwana mara she's taking long rona ba emetse ke rona ba emetse
She must summarize this thing.
ke nyakile go
She
mo
must
stopa
summarize this presentation.
ke nyakile go mo stopa ka nagana gore ke gona ba fitlha mara o setse a boletse gore o a fetse tshwanetse a fetse Kgosi
Shall we continue?
Yeah. Hello. 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 Ra continue ane. Sharp.
Okay, thanks, Chair. Gonna skip some few. All right, we're not a malaria endemic area, but the patients in because of malaria, and we're planning also to make sure we other countries, neighboring provinces as well, patients from Tsona, banale malaria. So we just want to also just give you information. It's always best to seek health care. Just if and it's an emergency situation, phone EMS and we also make sure visible all our schools, not all, like the no paying fees, yes. So we provide healthcare services on a screen for problems and then refer also to other healthcare services, and most importantly we also screen Banabao for cancer. So please help us as parents to sign those forms, because Banaba those consent forms, so that you can give us consent to re-screen Banaba, screen also for cancer. It will help as part of prevention efforts to make sure no child dies because of cancer of the service. The other services already providing, we are planning for, to make sure we screen every time we go clinic, we go hospital, we screen for hypertension, high blood, particularly for mama, we screen again for blood which is diabetes, so that we can put you on appropriate treatments. So hypertension, diabetes are very important, and they can also be, prevented, and that is why I said earlier on that we're going to be emphasizing on health education and health literacy. Renalili ambulance, and we can see that every time informal settlements, they spring up in different places, but we are trying our best to increase the number of ambulances that we have, so that when you do make a call, you can then obtain that service. But I also want to mention that we've had instances, people just call the hotline here, EMS, just for fun. Every time you call that hotline, there's a person that attends to you. And who knows, that person takes the opportunity and needed that ambulance for real. So please, let's encourage our youth, our whoever, that it's important that they don't do prank calls, EMS. So as I conclude, we also run a program, it's called Ccmdg Program, and this is where it's program 7 here. This is where we provide or place, but receive chronic medicines, either for HIV or for diabetes and hypertension. We remove them from the clinic. We want them to get those medicines closer to where they stay. So even MEC has found her program here is very critical. She will be working together with her office to make sure that she goes into communities and helps Bomme Bontate who enroll in that particular program. So please do enroll yourself so that you can get medicines closer to where you live. That's the Ccmdg program. So because of time, I'm going to end here, because the next set of program repeats the kind of priorities that we've been speaking about. Ke a leboga, Chairperson.
May Adelegan for that presentation, Yadi APP. Ke tshepa hore stakeholder le ngwadile di-question. A ke re o presentile hore ba tlo dira eng. So lena le ngwadile, o boletse le ka bo literacy program in the community. Ke tshepa hore le a di tlhoka di-community. Le ngwadile hore ya ka ke kry-a kae le gore le kgone hore a fe input ya ke re ha tlo responda. A ke re ne le ngwala le tšea di-notes. Tshwanetse le tlo botsisa. Re ya ko ya dilase ke di-questions tse rena as committee sa leng ra di romela ho bona hore ba di arabe. Re kgopela hore if e le wena o continue ka go responda to those questions. Sebaka e sa le sa hao. Lena ba le tlile re setse re thomile re a leboga gore re fitlhile. Be re le emetse hore re re go ya ka rule number 56 subsection 1 and subsection 2 pleke e re leng go yona re declare holo e ya mo re leng go yona as the legislature. So be re emetse gore le lena le be teng ge re declare. Re a leboga. Oh, lena le fihlileng tšhetše re thomile ba tla lefa le pampiri e so le tla kgona go kry-a information. A le so e kry-e a e utlwagale. O ba re di fedile mara ba tla di organisa. Re tla le checka gore le ko kae le kgone go di kry-a.
So that came down to 6.
Oh, according to the number that was given.
But the 100. Chair, I'm just waiting for them to load the resolutions, the questions. Thank you, Chair. There were questions that the department was requested to respond to pertaining to the annual performance plan. The first question was regarding the removal of targets for XDR from an MDR from the APP. I will be taking us through the response by the department. So on an annual basis, we obtain what we call APP sector indicators from the National Department of Health. And this, APP sector indicator framework guides what goes into our annual performance plan. So for this particular year, some of those indicators were removed at a sector level, and that is why you are not able to see them on our, current APP. The second question pertains to infant PCR. So in the APP that we submitted to the legislature, the APP for 2022-2023, the target there, it's not 12% as outlined in the question. The target is in actual fact 0.75%, and you can see that target, that 0.75% target on page 80 of the current APP. Question 3, we were asked what are the names of the companies that supplies PPE. We have listed them on the presentation: Central Medical, Chemical Well, Dynamic Pharmaceuticals, Evergreen Technologies, and so on and so forth. So that is the list
of the suppliers that are providing PPE. In terms of how much percentage, from 30% is including entrepreneurs from local township. You'd remember in my presentation that I said the department has committed to have budget spent 30% of its negotiable goods and services budget on townships. So we are, as in terms of this financial year, the target is 30%. However, our previous performance has been at 18%. The next question talks to Cabo. It's a two-part question. The first one speaks to the manual filing or digitization of records. The second component talks to picture archiving communication system. So the picture archiving communication system is those radiology, the pampiri tsa X-ray, the picture tsa X-ray. That's what PACS is. And the manual record ke paper file, paper file. So in terms of our response, the strategies the department is also using, we will be deploying PACS to 18 of the 36 CHCs. The remaining CHCs will be included in the next financial year. Why not everyone, why not all CHCs this year is because we need to make sure radiology equipment in all the CHCs before PACS or picture archiving, this picture archiving system can work. In terms of digitization of health records, we will be making sure all the paper records are digitized, and we are currently finalizing a process award a contract to a service provider on that. In terms of strategies that are in place to ensure that the current budget improves procurement of goods and services, we are addressing whatever challenges that has been there in terms of supply chain by making sure all the SCM officials or people who work in that particular environment are trained on all appropriate, policies or relevant policies and procedures, so that they can then work according to those inventory management policies, knowing that when you work in a hospital and you've got a particular stock at a particular level, you can then start, ordering so that nothing, iba short for that particular facility. We'll also be establishing the contract so that we don't, when our healthcare professionals babata something urgently, they can source it directly from that contract without calling multiple suppliers. We will also be committing to pay at least 80% of suppliers within, 80% of the invoices within 30 days, so that the suppliers can continue to have also the capital to reinvest into the system. We are also introducing what we call a reorder level and quantity recalculated for all inventory items, so that again, stock management in management and people don't hoard stock, but order what they really need for their facilities. And we have also introduced what we call a procurement plan, and this is a plan that specifies what each hospital or clinic wants to procure, and anything that they want to procure that is not outside of that particular plan, they will have to motivate for it strongly, so that people don't buy unnecessary things that won't provide or help us provide proper care. The question on EMS, why did we change the target for urban from 15 to 30 minutes for P1 response? again, it goes back to the national government. So every 2 years, national government has what we call a district health information management system, which comprises of indicators, and these indicators have to be reviewed every 2 years. So when we review those indicators or measurements, we also review the trends. Over time we review, we look at where there has been new locations. So we consider quite a lot of historical trends analysis to check what would be the most realistic target to be set for a particular area of intervention. So when they looked at those particular patterns, they then, came up with a guide to say for urban response time, EMS P1 will be 30 minutes, and then rural will be 60 minutes. Again, for rural, considering, the type of road infrastructure that we have, as well as, the settlements that are springing up, in their locations. The next question, okay, it talks to maternal health. So the question was talking about allocation of baselines for provincial hospitals. So our baselines are basically historic data. So if this year we performed at a particular level, we look at the resources, financial resources, human resources that we have, we look at the burden of disease, that we have, and that helps us to estimate by how much should we reduce, maternal mortality. So for regional hospitals or for central hospitals, that is basically what, we had to consider when setting those particular, baselines. The next question talks to, again, allocation of what is the baseline for allocating targets on severe acute malnutrition. For this, later during last year and this year, national government has modified slightly the severe malnutrition indicator. Before, in the denominator of that indicator, we were counting neonates. So people that are well versed with, pediatric care advocated for the removal of neonates from that denominator. So that is why when you look at our APP, this current APP, you will see that there are hashtags or blanks in those baselines or targets, because it's a completely new measurement which has a modified denominator value. In terms, what is the baseline for allocating targets on ideal hospital? So we commenced with the ideal hospital framework since 2019. And when we started, we saw that our performance was quite low. We had only, very few hospitals attaining this ideal hospital realization. So from then on, instead of targeting all hospitals, we only targeted to have around 60% or so of our hospitals as ideal. But by end of this term, we intend to have all 100% of our facilities complying with this ideal hospital realization framework, because that is one of the critical areas that will also help with the readiness, for NHI. The other question talks to allocation of target twice. So earlier on, I spoke about allocating budgets according to different programs. So our APP has different programs. So within program 4, which is a provincial regional hospitals, we've got your normal regional hospitals. Hospitals like Mamelodi is a regional hospital, okay? It can refer patients to Kalafong, to Steve Biko. So within the APP, we've got that, the layer of regional hospitals, and then we've got a layer of specialized hospitals. This is where Vescopies can offer mental health care, where patients with TB can go to Sizwe Hospital. So the targets for Ideal Hospital speaks to both, you know, regional as well as specialized, so it's not repeated, Chair. In terms of why is maternal mortality rate at tertiary level not having a baseline data, we've got, yes, at tertiary level, which is program 5, we actually have in page 96 and 106 of the APP, we do have the estimated performance, or you know, the baselines for that. So it is there. It might have been missed maybe during review, but it's there. The last question talks about capital infrastructure. Why it didn't have baselines? It didn't have baselines because it's a completely new program, infrastructure program. So I think from now on, I mean, every time we report on performance, that will use that performance as a baseline. I think this is the end of the questions, Chair.
Thank you very much for those questions. Ke nako ya di comments le di questions. Ke tlo khopela re emise matsogo ke le fe di number ge le nyaka ho commenta ka presentation ya pele vote 4. Le ya di APP vote 2, I mean ya di presentation number 2 ya di APP le mo di questioning if le na le something le dumelehile hore le ka bolela ke tla starta kam re emisa matsogo go fa nomoro akere ha o bolela o tlo re ke nna Rebecca di Hamela ke tswa proclamation Hilly, and then wa bolela question ya hao. Number 1, number 2, number 3. Ke thoma hape emisang ka lefya. Emisang ba bohle mo e le nyaka ho bolela ne. Number 1 says yes. Wena. 2. 3. Yeah. 4. 5. Councillor 5. Where Mr. Telso? Oh, we're now at number 6, says. 6. 1, 6. 7. 8. 8. 9. 10. I was an welcome. 1, 2. I was an alele in the Get 2 fella come on there. Yeah. So it will be 11 and 12. Number 1. That's how far Mike. Number 1 is Abuti Kamumra. We're now 6.
Thank you so much, Chair. And Kialabua Hori, MEC Arona Onalerona, including Dr. Masuku Pandila, Ilanga Sebeta Handle in the past. Program Director, I've got 3 things. One is around, as and when the presentation was made, I just hear Hori, there were certain millions, 6-point-something million, which has been returning back to the treasury. I've got a problem with that. I've got a problem with that on the basis that how do you allow the situation to go?
Sorry.
My apologies for that. Ke Meshak Mutibedi from Sidibeng. and Fulane. Ishwaka, it was around a presentation which has been made already, and then I hear the slides where quite number of millions have to be turned back to the treasury. And it's unfortunate that at a population of more than 14 million people in Gauteng, and health is one of those, a critical department. I want to understand what makes this thing, that the money has to go back to the treasury. And what plans are in head so that we ensure that at least by 2023, you don't take money back to the treasury, but money have to be utilized in totality. And another thing is that I just also hear that there will be another amount of money that will be going back to the treasury. Surely something has to be done. You must come up with programs that will ensure that no money is being taken back to the treasury. The second other thing is that in CDB, we really appreciate the services which we are receiving around health. Our communities have been encouraged not to go to the hospitals, rather utilizing their local clinic for their different health matters. I concur, I like that. However, in my area, because I'm also a CDW, we've got, the population has increased. We have quite a number of teenage pregnancies in the local area. We have a local clinic which is open from 8 o'clock up until 4 o'clock. The challenge is one. This clinic has to cater for people in Garden Gardens, Zone 20 neighboring areas. It doesn't have, at some point, there is a challenge of capacity, the human resource part of it. And it doesn't operate late at night. So my appeal is that, can you kindly prioritize that clinic to operate even at night? Lastly, I want to commend the Department of Health in Gauteng. There was a slide in whereby we hear that young children, the ladies, in fact, teenagers got pregnant. And this information was shared with the Department of Social Development, and it was known to all of us. We appreciate that, sad news as it is. However, I want to take it back, forward to say, can the department also, because they are receiving these children as and when they are going to give birth, let us also know the people who were engaged in sexual intercourse with these children. It cannot be teenagers only, the young, the girls. Let us also know who are the fathers of these children. Thank you so much.
Thank you very much, Mr. Mutibedi.
Good afternoon. Ketato Marco from here in Tshwane. And right now I'll be representing one infant organization and the other is a big one. I'm representing Pale Youth Conference Forum and also South African Tobacco Free Youth Forum as a regional coordinator. I'm going to be very short. I'm going to be shorter than myself. So on the presentations I've heard that there'll be health literature. But then also I just wanted you to know that we have a program here in Tshwane. We have implemented this program and we've been trying to get hold of the department so that we can work with. The program is called #SafeAbortion South Africa, Right to Contraceptives. What this program is about is that it doesn't encourage abortion, but rather it says we should eradicate the stigma that's against people who need to perform abortion, and also enforce to parents that they should encourage their children to use contraceptives, because we don't need another 10-year-old getting pregnant just because a parent doesn't want to accept that these kids are having sex. So, also wanted to comment on the issue of the NHI. I believe a setback to the NHI is the tobacco industry as large, because it is as a negative externality to the government that tobacco industry costs government 42 billion every year, but it only contributes 12 billion towards the GDP of the country. And it is also a foreign direct investment. We don't have a tobacco company that's formally from South Africa. And then in that pace, as I'm still on tobacco, I believe health department is not helping us. There's a bill called Tobacco Control Bill. The Department of Health, you are quiet about it. And we see what's happening on TV. There's literally a scene where we see but then the Broadcasting Compliance Commission of South Africa says that they don't allow the SABC to actually broadcast a content that is harmful to children. But then the same Hablio thing, it's harmful to children. But how will they know? Because it seems like the Department of Health has forgotten that we need to control the tobacco so that we are able to also find a way to eradicate the negative externality that tobacco industry caused to the state. And then lastly, I just wanted to find out from the department, what is it that you are actually doing about the indigenous knowledge system of medication? Because then we had the president talking, we hear people talking that the those kind of people, those kind of things. For an example, Pache recently it's allowed to be used with medicine and stuff. But then these pharmaceutical companies, how does the department actually regulate such things? Because department can only blame again. You are not regulating these things and you are not taking us serious. But lean. But Sprite. But what is it that we are doing through this health literature programs that you are doing? You are not saying anything about it. You are not saying this thing is harmful. And or this thing is a trend. Limo TV still, but the music video. But the department the people the danger of such. On that note, too, thank you.
Number 3.
Afternoon, Kina Tandega Mngobe from Atteridgeville. Negarato Butisa Kadi Clinic Committee members who are they getting any stipends? Thank you.
Thank you. Number 4. Sorry, Nisi.
Khotso, ke go Patsebe from Atteridgeville, Phomolong informal settlement. Ke be ke nyaka go tseba ka taba ya duration ya di ambulance, because ke kwele go allocate wa tšhelete ya di ambulance. So I'm asking gore le na le dipalopalo tše le gore le a lemoga gore re na le go itemogela go shotha ga di ambulance na, because go re tšea telele go emela ambulance ge o emetše go na le mathata a re taba re kopane lona re le ka gae. So re ke kry-a le gore re fetša tekana go lekana hour-a goba go feta re emetše ambulance. A ke tsebe ka mo lehlakoreng la lena gore go na le nako time frame ye le gore e beile gore morago ga ge o kirile call, because nako e ntši re na le go eletša batho gore ge ba dira call ka re ba bolela gore re khotile go be le reference ba tsebe gore ba bolela le mang gore re kgone go ba thusa ka go dia di-follow up. So mara ga ke tsebe ka mo lefapheng la lena gore le na le time frame ya gore ka moraga khole e tswele e re khopetse thuso ka kalafong gore e tle gore e tla tsena go mang go tla fita go phomolong. A ke tsebe re nako e gona ka re go lena nang ke sa matho mo tsebe ke le ke se labalabela gore le se tlhokomele gagolo in terms ya go allocate di-ambulance gore a di be enough mo le gore re ka se ke re go ga boima. Sa bobedi ke lemoga lebaka la le mogalabe ya gešo a le tsweletseng ga a thoma gore tšhelete e boetse morago. Ke na le kgopolo ya gore tabe ya go oversee go banto ya go tlhokomedišiša ka gore ke kwa maleme a mabotse a le a bolelago polelo tša lena le tlhapile di a kgatlhiša fela ntse ke se lemogang ko gore a gona nto ya go kgonthišiša gore tšeo le di bolelago di a diragala mo ditleliniking le mo dipetlele. So ke lemoga gore le a iketla la dula fase ka tumelo ya gore se le se boletse go se ta implementiwa mara ga le se šale morago go netefatša gore seo se a phethagala. Ke a le kgopela tswetswe gore mo dipetlele le mo ditleliniking tšea matsapa gore kgafetša le etele ko dipetlele le ko ditleliniking go netefatša gore tšele di bolelago di a phethagala gore go sa sa ge re tlo dula mo re se ke ra boela morago ga di-question tša go swana le tša lekgono re tšwele pele. Ke nyaka go feleletsa ka gore ko di-areeng tse ka moka ke be ke duma goba ke be ke lakatsa gore go be le ditleliniki tse di berekago 24 hours. Go etša rena ka mo Atteridgeville ga rena tleliniki e berekago 24 hours. Bontši ba rena gore re ka go fela ga rena re senyo re kitimele kalafong and rena le ditleliniki tse pedi ka mo Atteridgeville tše le gore di a operate goba tse tharo ka mo Atteridgeville. So re kgopela gore go be le tleliniki ye le gore e operate 24 hours a e se ka ba kalafong fela e le gore ka go fela ga rena re ke kry-a re ya kalafong then go ra gore ro ke kry-a re tletse kalafong ro boa gape ga ra re kalafong ga e fe service go ela ka fa e swanetse go ba ka gona ka baka la gore ka moka ga rena re tla ba re ya kalafong pele tswetswe re a kgopela gore netefatsang lebaka la gore re be le tleliniki ya 24 hours le ge ka ba tše pedi a o le tla ba le berekile bana ba kgoši re a le leboga.
Le tshwanetse gore le be specific ge le bolela wa bona ne. For example morena kgopa gore tshwanetse department e fele e etela dipetlele le ditleliniki mara a bolele gore bothata ke eng. Tshwanetse o be specific gore bothata bo wena o bo boneng ke eng gore le rena re tloe mo re re okay bo bone eng tshwanetse addressiwe gore ba thuse ke re morena kgopa at least for yona eo ya ditleliniki at least re go kwele gore ditleliniki di a shorta wa bona le di-ambulance a di tle ka nako wa bona tlaleletsa ela ya number 2 we linkile le budget or le return of money sharp.
Ke a leboga mosepediši wa modiro ke be ke bontšha mo lebakeng la go etela ko ditleliniking le dipetlele gore go le gontši o ke kry-a o le ko lineng ko ditleliniking ba na le go goga maoto ba go se tlhokomedišiše lebaka la methaladi ke ra tsona di-line ka gore o kry-a batho a ba tlela nto e teng mara ba eme go teng. So ntoela e lapisa motho tlhaloganyo go lemoga gore o ka re a ka se kry-e thuso ka moraga go bona re tletse go lekano ge nto go ka ba le nto ya go categorize goba go ntšha ka diripa gore ba batletse go di-prevention ba emela ka mo ba go tla go tšea dipilisi ba emela mo ba nyaka go consulta ba emela mokwe ke ene nto e netefatšiwe gore go be le nto ya go bereka e seng gore le gona babereki ba lena ge ba fitlha kua ba re kry-a re dutse kua e ba senyo ba re thuse ba re ke breakfast. It can't be a re be le batho ba ba rata go mmereko ba o dirang gore ge ba fitlha ba thome go thuša batho ba ye ka go tšhentšhana ga bona e le gore line ya sepela a ke go leboga mosepediši wa modiro.
Thank you. Number 5.
Yeah, e re ke tšee sebaka se ke go leboge mosepediši wa modiro ke nna phasha wa ga phasha ke tšwa ko ward 71 partially di-speakera tše di boletšeng mo dinkgabarile ke tshwentše ka go dula kgauswi le kgopa ka gore o boletše pointe tše ntši tše be ke nyaka go di bolela but let me just continue ke tlhalose gore I'm very happy because ke kola ba introduce mo gore senior officials from Kalafon they are here and then ke tlhalose polelwa gore re na le overload ko Kalafon hospital batho ba ga bo rena ba fola line e telele and nna wa ka nna go ba khudišo ba go khudiša ka yona ga wa swanela gore o eme line o le moletši line o ka emela ya tšhalete fela Dr. Dikhamela e sego ya ge o alafiwa a se setho is inhuman gore moletši a eme line so ke tabebe ke nyako go e toucha eo and second to that ke nyako go toucha issue ya di-ambulance le aware gore mo Tshwane masepala is doing away with ambulances so provincial government our humble plea is that please ge le dila ka issue ya di-ambulances santse le extend then let's make an extension of hand because municipality currently a o sa tlo ba le di-ambulance gore re tlo sokola go feta go sokola mo le be re sokola pele so gore re jole ka gare ga tete ba bothata jo bogolo re gopela gore that area e lokišeng le se ka tlhole sa boetša budget morago buy enough cars hire enough staff so that our people can get a quick service from that particular area and ke tšwele pele gape ke se ka fetša moo ke tlo ba e moteletšanyana ka gore ke nna councilora kua woteng yaka wotela mo di-woteng ja rena re na le kore ke nyako dumelana le seboledi se se bolago ka 24 hours clinics ge be go kgonagala ka gore MEC gona nke le ka bile tša resolution ka mogare ga meeting gore go tloga mo a re tsena ka gare ga office ro converta di-clinic tše di leng mo areeng ya Atteridgeville to be 24 hours service clinics ka gore a re sa emetse sele go congested every time ge o tloga o re o theoga ka koloi line ya gona le bile go latelela ka mo tseleng ya gore ba thušiwe so e ra gore the demands is too high that is why seboledi se se re a fa go na le oversight na area go area ke legislature together with your departments in those particular area health facilities is our concern and le gona ge o ya go far west of Atteridgeville re gopela gore department ya ge clinic e nngwe o tela ke dula go yona ina le 7,000 households it's 16,000 population the influx is worse gore metlele re riziba batho ba baswa ba ba tswa from different provinces to come to our province it means in essence gore re sa tlo ba indefinite congestion in those particular clinics so department ga e dutse tiketlile then gore re tlo ba le mathata mehle Dr. Dikhamela as a chairperson I'm happy Pandile Masuku is also here gore re le tshepile thušanang ka majoko awe a maphefo go netefatša go ba go kgontišiša gore community ya gabo rena e hwetša thušwa maleba ka nako especially on that department ya health so ke se re se kgopela go tswetswe ke nagana gore gannyane ke di khabarile mara ke nyako go gatelela mola ka polelo ya seboledi sela gore part of your reason why le ka mogare ga government ke gore le a tseba gore COVID e re šietše le bothata unemployment in particular go ne tšhelete ba re boela treasury e le gore ka yona nka be le tšere at least like exhausta in different avenues of those departments go netefatša go kgontiša gore lo oketša staff le ntšha di-learnership le hula bana bo rena le di ametlholo ka mokana ga yona e le gore tlo gola setšhaba particularly black people in particular so e re ke e tlogele mo ke se kanape ka ba ye motelele but those are my submissions ke gopelela gore le di tšeleng tlhoko ke a leboga
Re a leboga councillor Pasha number 6
dumelang nna ke nna Happy Manyathela bontsi ba dilo tse ke tlo di buang setse ba di bontsi ba dilo tse ke tlo di buang setse di buile mara ke tla tshwanela ke gore ke di gatelele ka gobane ge re di bolela re le ba bantšhi maybe department e tla utlwanyana ne yeah so ke tlo bolela ka EMS ra sokola ka di-ambulance e tla tla after 2 hours or he re ba founela ba bolele re bona ba tsene ka mo mošonko kgante rona re batho na and the department e didimetse ka yona taba eo and again ba re okay re ke tle mo ya issue ya ka engwe hape ke ya di-lean go na le setlhare sa mokhutlhwane se e leng gore youth ya se overdose, and the department is quiet about that. And hape ba se reka ko pharmacy. And then again, ke tlo khopela ho botsisa ka
Sorry. Ke setlhare se se feng se youth is abusang?
still paying, ba se bitsa still paying. Syrup, ke di cough syrup, some khutlwana.
Oh,
yes.
okay.
Ne?
Ke cough mixture.
And then again, ke tlotla mo in terms of health education. The details tse le ka re fang tsona, because now I'm under the organization ya dipeu tsa Tshwane. How do you give because kutlile ba re they have to partner with the organization and stuff. Rena re bereka ka these kind of things. So ke nyako itse hore how do you give us the details ro di tsa kae tsa health education hore re tle re khone ho bolela le the other youth since well le sa khone fitla ko bona. Yeah.
Can I ask Kisheli Manyathela to come already atlo tsia dinomoro mo le bona o ba fetsa hao before re tlo lebala. Number 7.
Dumelang, ke Sephuwen Tlhapo from Val. Ke bua ka Val Vanderbijl Park. Ke sebetsa le ABCDE. Ke tlo ntshwarela batswadi. Batswadi ke tlo bua ka Bophelong Clinic. Bophelong Clinic e nyane. Ho tla batho ba bangata every day mo country ya rona, especially ko Gauteng. E nyane Bophelong Clinic. Jwale ntwe ke ipotsa hona the criteria or le etsa budget ya lona le entse ke batla ho tseba ka criteria e le entseng ha le etsa budget ka criteria le sebetsitseng ha le etsa budget e le re fanya yona today.
Hello. Number 7, can you ke khopela hore botse gore ko wena mangwa ko kae?
Ke boletse mma ke tla peta hape.
Okay, sorry ne.
Ke mma ka tsa rhetoric. Ke nna Sephuwen Tlhapo from Vanderbijl Park. Okay. Ne ke botsa ka criteria le sebedisitseng ha le tsa budget because Bophelong e nyane and hona le batho ba bangata ba tlang clinic eo. Bophelong ha ena labor what bomme ha ba tsone ba pepe ba ya Johan Haynes and it's too far. Ya bobedi ke utlwile mme a bua mo a re budget ba e etsang ka jeno ba tlo fanya yona ka jeno. But we may learn a leading organization, which I'm a little bit worried. Who want bona bat bao ba tseba the population ya le question in now, because re na le batho ba tswang Africa ba tletse le question in la rona. Yes, I speak now. Mind you, government have bana ba sekolo tšhelete ya dijo ya grant bana ba tswang ka ntle ba thole tšhelete eo. What about the budget? But what's on country Africa? Back in which budget? But to runa by clinicing, I want medication about Tola. Yaborao. Nebata Tebaka time frame. Yao build the clinic. Time frame, Meli Sevisang. Or criteria Sevisang. Yao build the clinic. Yawone. Kiwata Tebaka accountability. Because as you came here, the kilo rona kutlule le bule ka treasure what or alisa total lona o yena la mo fa check on the total lona the right but ke batla tseba accountability ya lona le account ya bomang because according to me tswale le khotela o rona tlo account ya rona. Yes, I saw Nova the questions are previous uzama di Arab, but we need to be clear and straightforward hold account ya bomang. Because this is a even then every time we try an IDP, NDP, we try to budget. I right, Kialebo.
Ralebuha for the input. Number 8.
Dumelang ke tapele ka mo. Ke Joseph Bakamkhisi, ke tswa Bophelong. Vanderbilt Park region. Number 1, shortage of staff. Number 1. Number 2, yesterday there was a child who died inside the clinic. Bophelong clinic. Ka baka la hore inyane batho ba ema ka ntle strateng ba hatsela la o bata tje. Lona jwale ba ntse ba hatsela. Number 3, it's then been 15 years since we come here. You promised to build a clinic in Bophelong. Nothing you have done. 15 years, re tla re tsamaya ka mora legislate. Re lata 5 years e ngwe le tlo fa yona hape. Re sa thole next. We still stand outside the yard, even in winter. Batho ba ntse ba hatsela uswaka. Batho ba hatsela ba shwella ka ntle ya clinic. Clinic e nyana haholo. Ke tla ka mantswe a ntate man. Assistance with ambulance, please. Yona tlamehile re thuse ka yona, ra le kopa. Amen.
The ambulance. Thank you. Number 9.
Oh, ke me Lydia Mama Diva Maria from Bophelong Vanderbilt Park, a spiritual self-employed social worker. Dumelang bana ba Tharientsho. Re a leboha ho ba teng ka monana. Fela ke batla ho commenta ke re kaofela ka mona re batho ba batsho. Ka mantswe a mang batho pele principles sentse le apply. Re kopa e apply even more. Department re kopa ho e challenge because it's still applied superficially. Ka di concerns nentse batho ba di raiser 28 years of democracy santsane re complaina, then it means the batho pele principles ntse di le mo leboteng. Ya bobedi, South Africa is still a dumping zone. Ya dijo tse e leng hore they are unhealthy, they are cancerous. Be it go dispenser shopo, be it go the anyway, every other food outlet. Now and then more TV, ho hlahella stories sa hore ho fumaneile dijo tse e leng hore they are cancerous. Again, ki challenge e re kopang ho lefa yona the department hore can we see or can you strengthen the visibility of health inspectors at all levels, haholo ko makeisheneng. Ha se ntho e re sa itsebeng hore di-tuck shop kaofela ra tseba hore 90% ya dijo tseo they are self-made and they are against the regulations tsa health. Our children are dying, re ba shebile. Can we do so? Can we have tsona di-committee tsena tse e leng hore ntse le di kgetha at local level? Can they have this stipend thing? Kore e be strong visibility to ensure hore batho pele principle e ba applicable 24/7. The digital system le buileng ka yona ra e thabela ebile hape ha re e thabele. I'm a person or promoting black consciousness. We need to start competing with the fourth revolution. Africa has got its own wisdom. The IKS, Indigenous Knowledge System, comes from us Africans. Ha ke bua tjena, okay, for the digital system, the question ke hore more often than not, issue ya the system is down. Now within the department, dipetlele, di clinic, di how low but the ID or in system is down. You go there 3-4 times, get taxi from a person who don't have a. So how learn to strengthen into the digital system? How are we going to make sure there won't be the hiccups out on strengthening the energy system along is supplier the devices to the department. And high low devices happens as individuals. Again, will there be concession for like indigent families. That is, I'm not very sure at what level are you going to have the digital system. Is it just going to be good clinic or even deploy limo into a good party on next hand? But if it lower to a point the cell phone and then let it go down, trickle down to the lowest level, again, Batho principles. A strong working relationship between the department, the traditional department of traditional affairs and department of culture or national heritage council. I'm a spiritual healer, a traditional healer myself. It's very, very painful. The other day, Mo TV, indigenous IKS, we have our own wisdom, but the whole world is making billions, trillions of money out of our own wisdom as Africans. The other day, cannabis. Yes, we were happy for Eco-Val Triangle, VUT is going to create jobs, but our ancestors didn't die for job creation, they died for job creation and wealth creation. Matekwan is our own herb as Africans. But the people who were spearheading the program, Motivi, it was 9 African scientists. And we've got our own scientists as Africans. So, serious as Africans, such programs, such budgets must focus on us Africans, the coral harem mense. What was the other one? Okay, the last one, I would like to request for a budget, a focus on strengthening I'm talking now the entire continent now, African Union. We keep on talking United Nations. Can we now start focusing on AU, African Union, us as Africans, the whole continent? As in the Richoro, we've got our own resources, wisdom and everything. It's about time. And every now and then you would hear Modi WhatsApp on presidents on other countries. They're actually saying that, so many years we've been colonized. Are we still following the Western civilization to date? Yet we know that we can do things ourselves as a continent. So let the budget focus, the budget, part of it, can it focus or go beyond or focus more AU as opposed to the United Nations for a change? And for that one, maybe I'll market myself. I've launched a school, it's still at infancy stage. It's called SSB Sekolo Sabo 2. Because if we are still eating cancerous food, then lack of Ubuntu on the manufacturers. So that's cool. If I have to come and give my address as well, I would rather do than be part of this union, the partnership, African Union, because it's about time. 28 years of democracy, let there be action. Ralevo.
Thank you. Number 10.
Dumelang le kae? Ke nna Itumeleng Ntsweng wa mo Ward 62. Nna ne ke nya go bolela mo tabeng ya o ya go kalafong ne problem e ke experiencing o kono fitla go sepetlele o lwala ba botse re tsa mo bula file bushiu na kweo o bula file bang o sa te kutlipila ke mo ke tla khopelang hore ka re hona le youth sense di sa berekeng ha ba kreme mereko bushiu ba bereke ba bulele batho ba lwalang di file because of o tsana go kalafong ka 8 ya bushiu ha o no rona mena taxi ka 12 cause sama thomo na mena di taxi ke batho ba ka ba re ipileng go santa ka wa kalafong ka matha because of sona dilo tse bjana so ne ke khopela hore ho change system bushiu ya hore batho ba bulediwe di file ha o tlile le one tlakatlakane ho bana le motho assistant ka o bula file and then ke we happy kan to happy ke experiencing again go teng 2 weeks back ne ke sengwana appointment ku ENT ere fitla ba re botsore motšhene o robegile so my question is why re share di phone number if motšhene o robegile ba sa re inform in time re tsa tšhelete rena tsa di lase rana mela re akala phone ha o fitla ba o botsa sebo a botsa you have to go back and ba o fe another date Ona batho ba leng hore le tšhelete ya ho namela bana yona, they walk from kwa ba nnang hore ba tle sepetlele. But while sa ba informe ba ska tla ba le ba feng the other date. Ntho engwe hape ke tlo e busang hape ke taba hore why does it have to be hore every time o ya sepetlele o tsene furu ka 6 mara o tswe ka 5 mara o bona doctor e one o emisa ko re mba o botsa hore ba nyaka file ya hao batho ba emela file more than 3 hours guys every time ha o fetsa o kry-a file o ya docteng ko docteng ga o senyele nako mara ko ditlhareng o ema another 4 hours. So what about batho ba leng hore a ba khone wa foto reka dijo gore batho tsentse ba rwale di captain for dilo tse leng hore di ka change-iwa fela if batho ba ka kry-a mmereko le hore change-iwe le system ke we hape ke hatelele e ya di ambulance. Guys, this thing ya di ambulance is serious but le rena as batho like wherever we are ho tletse di vulture. There was a time batho ba ambulance singile ba rapiwa. I think they look ba re ke kae ko tsetsela tsa forest hill kwa. So, le bana ba tshoha batho ba bereka go di ambulance. So nna ne ke suggest how about batho ba healthy ba thima pele batho ba force hore if the ambulance ya go plekeng tse leng hore la bona hore are di safe. I'm not saying Moshengo are safe but we all know hore o rough. Ba bana le backup ba mapodisha guys. Then le tlo bona hore le di ambulance di tlo tla in time. Wa utsetse ke nne ke khopela and then e ke khopela ntata especially mo di clinicing. A ke tsore le ka se khone assist batho ba holo le ba batho ba leng disabled ka taba transport o khone kopana le ko fela moholo a totoba a ya clinicing ha fitla go clinicing o nna a totobe a welle e se re itse malapa a lekane so ke bona ba ne ke ba khopella le di hole tsa borena hore ka tsatsi la bona la check up at least ba kre transport e ka ba lata mo gating e tlang go Department of Health ke tsona tse ke di khopelanye ene ke khopela hape le hore how about the team happy for the security good clinicing? This thing I am like good clinicing got 6 months monthly. It's not fair and it's not safe. Hepula ena batho ba nela ke dipula motho wa lwala o tlile ka clinicing mar off o khatelega. Why o sa bane le an open room for them? Hore he ba bula clinic le hore ba ntse ka mo pelekele le hore e warm and safe. Ke ntwe ne ke khopela thank you.
Number 11 is this side, and number 12 is that side.
Dumelang. Nna ke Nozika Ngoya ke tswa Sedibeng Emfuleni municipality. Ke tla qala ka hore ntate Khoba health department ha yetse di follow up ha ne re le kwa David Tony last doctor ke le ka mofua ke chairperson ke le boa chairperson o entse bi kgathatso le di efforts hore amfe doctor e leng hore o tla nthusa ka bohlaswa bo etsahetseng Johannesburg clinic. Doctor unkile di phone tsaka a re o tla mpha mamang am founele till today. Di follow up ha di your health department. Engwe ke mang ka yona ke enana ke supplier hape nna ke a supply. Then ke thola invitation from health department. Ba re ke supply di wheelchair tse 140. Ke etsa di efforts tsohle ke a quota ke etsa everything. Then ka letsatsi le ba itseng ba batla di wheelchair tsa bona e ne ile la bone se ke thotse le motho a tlo supplyang ka di wheelchair tse 140 se ke tlamehile ke nke tšhelete ke lo ikenya accountong ya motho a tlo mfang di wheelchair tse 140 tse ke di tlisang health department ka la boraro ha ke founa ke batla ho tsebisisa hantle hore mo ke isang di wheelchair teng ke kae hobane address ene le teng e le ya Pretoria. Ha ke phone ho araba ausi o mong only to find that hore ke le Nigeria mare o na le information ya health department kaofela o dula an invite every day le maobane every day o dula an invite ke botla ho botsa hore health department ntho tsa lona di tholahala ha bobebe hakalo hore bo brother le bo sister ba rona ba hlahang di country tse kantle ba re nkele tšhelete ka baka ka lebitso la lona la health department. e bohloko hobane ke be ke lahlehetswe ke tjhelete e ngata ene ke tlo e nkwaela fela tjena ha qeta ho kenya tjhelete e nyametse e disappearile nna ke emetse ho tlo deliver ke ntho tse re hlahelang he health department re kopa le secure information ya lona e se ke ya tholahala ho mang kapo mang and engwe hape ke enana ne ke tla ka yona ke ya hore ditleliniking re kopa hore ha le ke la re tlisetsa ke mammogram or mammogram e tholahale e be available basadi ba shwa ke breast cancer ne re kopa hore e tholahale o ska thola go tlo fuwa date o so iswa bara kapo o so bukelwa date ya kae ka nako no lampo ya hola ka hara letswele ke tsona tsene ke kopa ho bua ka tsona tseo and engwe hape ke tla khutlela hape hanyane tleliniking ya bophelong ne re kopa hore ha le ke la re thusa ka tleliniki ya bophelong la tlosa dikatana tsela tse tletseng se sa rauntileng ntho tleliniki because ke nana hore le tsona ntse di affecta health ya rona batho ba ba rekisang diphahlo ha ke khone ho tlisisa hore baneng ba tlameile hore ba surround tleliniki ka diphahlo ba rekise diphahlo tsa bona mo le di sitsa le manese ho sebetsa hobane ba ya mono ba lo kgetha diaparo ba itekantsha mo fatafateng ne re kopa hore ka baka wa lona le health le a tseba ka tsa bophelo diphahlo tseo le tsona tseo di ka nna tsa re kudisa hobane ha se ntho tse ntjha ke ntho tsa kgale ntse di pakelwa fela di tla di tlo alwa mo le diteki tsa teng ke a leboha thank you
thank you Nozi number 12
Ke a leboha ke le dumedisa ke nna Provin Mokoena from Atteridgeville ne ke rata ho botsisa under APP hore when is the forensic pathology service information management system going to be implemented? That is the first question. The second question is also how is the forensic pathology information management system linked to hospital mortuaries? And the difference between forensic pathology services and forensic medical services. The last question is, I've heard Mbolekwa Hall is encouraging people to register to render the services.
Mokoena, can you repeat question 2, please?
Okay, it's how forensic pathology information management system linked to hospital mortuaries. And also the last question, if you want to render the services, you must register. So I'm asking how do you make sure or a way for SMMEs with creative and innovative ideas that they are given equal opportunities with bigger companies providing the same services? And lastly, I'd like to ask how is the department handling the issue of unsolicited bids? Thank you.
Ne re na le matsogo a 12 ba mpoditse hore go na le 2 or 3 people le bona ba nyaka go comment ke tlo khopela ba 2 or 3 bana bao wena please o ska no bolela re bereka ka lenaneo ne ba ba nyaka go bolela ke tlo le fa 2 minutes each gore re fetseng a ke re ne ke le file chance ene a ke nyake lena le tlo bolela le repeat se se boletseng ke ba le ba fitileng a ke re le bolele dintlha tse dintsha ke tlo le fa dinomoro ke khopela le iketleng ke tla thoma ka number 1 2 3 ke na le 3 fela ka mo a ke re 4 5 6 7 8 9 2 minutes each if o bolela beyond 2 minutes go stela phone ya ka itompotsa ene a ke re lena ke lena ba le re reng ke lena ba brain drain ya ke le fa chance re tla thoma ka cancela mo
a ke a leboga modulasetulo ra itse gore mo Tshwane a rena masepala o ka mo tlase ga a coalition government. I would plea gore issue ya rena ya IDP as far as health is concerned e be responsibility ya health department ya province because we are struggling to have or to get things implemented because of the situations that we find ourselves in. And the second thing ki issue ya kalafong, if we can just emphasize issue ya gore ko kalafong go bane le security, le issue ya dijo. I got a complaint last year about a tibeke of abanloetse day. The last thing happened ke batlang hore re emphasize, we have young girls mo motseng ba ba irang di massage. And MEC, you know, massage it's not a luxury. It's something that can assist when it comes to health. You can be massaged and not get a pill for you to get healed if not pain wherever mo mmeleng wa hao. So we have group of girls ba beleng gore we can maybe assist them to be part ya ka mo dipetlela, like the physiotherapist, and get them empowered in that way. And my last thing ki issue ya gore we have parliamentary constituency offices in our townships. Can we also capacitate those offices? Because ke tsona tse di thusang as stakeholder relations. Issue engwe hape ke issue ya staff sa rena mo dipetlele abana matla a go thusa setšhaba. Can we have a way ya go emphasize the issue ya batho pele principles in a way that gore ha ba treata motho ba mo treat like they are treating them ko di private hospitals? Ke a leboga.
Dumelang.
Sorry, Mama. Number 3.
Dumelang. Wa bolelang mo ke Melita Seroto. O tla ko New Stress ko Amaskral. Ne re kopa ba health. Clinic ya ko Stress e phua. Di services tsa teng tsotlhe di phua. O tloa fruka 4 o'clock o ya line ko Stress clinic. O bua ka 6:30 ya bosigo. Ke service ya bona. And then re kopa hape clinic ene ba re tshepisitse yona last year gore itlo agiwa ko Stress, re kopa e boe. And ha e bua clinic e re kopa gore ha le bolela le mo counselor a ntshe di politiki mo moagong wa clinic e ahiwe ka go sokola baagi kwala a go sokole di batho ba di politiki go sokola community e nnang ko Stress. And then ke tlo le khopela hape ba health gore le saleng morao dilo tse re di kopang le yang le o checka ko Stress gore service ya bona e byang. Ke a leboga.
Ke a leboga Melita.
Dumelang. Dumelang. Baetapele ko pele ke re dumelang. Yeah. Nna ke Adelaide Mofokeng. Ke nna gona mo Ward 62. Sene ke se kopa. Se kutlwang a se tshwariwe a se bolediwe ne ke health, and I think le sona se wela under health. Drug and substance abuse. Mo rena mo Atteridgeville re na le bothata bo bogolo ba drug and substance abuse. And then bana ba rena ba go kega every hour, every minute, every second. Go na le ngwana o mo one a bang involved mo drug and substance abuse. And then re na le bothata a re na rehab. Di rehab di ko kgole. Ne ke kopa gore go ka ba ka mo ditleliniking. Ne ke kopa o ka re go ka ba na le mo go na leng pleke ya di drug and substance abuse. ke bolwetse le bona isn't pandemic le bona ke utlwa a le bo bolele bjana ka tlhoba boroko ke tlhoba boroko bo bogolo ba rutswetsa ba tlhokofala ba itlhaba this nowadays ba itlhaba ebile ke a e bona e ya o nwa dipilisi bjanong what about e ya go itlhaba e okay organization e re nang leng yona ke organization e one ke COSAP e hona mo Atteridgeville clinic fela and then Atteridgeville ke Atteridgeville Sosville Lotus Moshengu koho le hona ho na le di clinic ka khola re ka kreya thuso le hona ko ene ko COSAP ba ba fa Stlhare se ba ba fan sona a se kgone gore a ba bulu every day ba kheta matsatsi ra re no ke ka labobedi ke ka labone ka re ke organization ha ana enough resources like henke ile ka mo clinicing or ile ka mo provincial hospital ne go tla ba motlhomong kaone go ka bana le pleke entseng bjao and then re na le pleke hona ka mo morao ka mo hona mo next door ya ntho e ne ile hotel mphe batho hotel ne ke o isha o kare here o kare re mella re fetsa mo re tsena ka mo mphe batho hotel lo lebela re mphe batho hotel ba demolishitse ne bjanong ge ka mola go nna di drug and substance abusers ka mola banna ka mola ba ira ntho engwe le engwe ya bona ka mola so yona mphe batho e why don't we use it for rehabilitation center or rehabilitation clinic nke he ke botsisa ka yona ba re ke e ka motlase ga City of Tshwane they can work together with provincial gore re khona go renovate mphe batho re ire rehabilitation center and then nna ke lebala go ipega gore nna ke na le organization le di colleague tsaka ke na le one of my colleague here ntho e re utlwile this morning ya gore go na le health department I've just off ramp ke na le mmereko o nkekile ko ona a kaya ko ona just to hear gore health department e teng ka re nna mosle nna ke fola under health department as an organization ya bazushi homeless drug and substance abuse and rehabilitation and ke le ka motlase ha City of Tshwane ka regional drug action committee so this year we would say the organization ya bazushi homeless drug and substance abuse and re ba heletsang re ba apiela because of the homeless ra ba apiela re ba fa di sopo from our pocket you are still new kona ne re register le SARS gona yano and then re batla le gore gape le ka mo at least le ka nke ka mo mahaeng bomme ke khopela gape le bomme ke sa khopele lena ba etepele ke a khopela rena bomme ke khopela gore bana ba lena le ska ba koba he ba tsuba la ba kobala ko kae le ba kobela ko mphe batho Kopela le ska ba kobela ko mphe batho ba le ska ba kobela ko kae or ko Moshengu or ko toropong ba ba matshaba ba ya ko toropong so ba tlala naga ene gona ba no bona ba re ba bitsang ke di homeless so rena bomme a re popeng nke re be ngatana e one re bone gore botlhoko bo re ka bo fetsisa bjang or re ka ba fola bjang we don't have future ya ka usana re sana bana rena batho ba ba ntshi ba tswantong ela ke di drop out tsa university ke di drop out tsa tertiary so how to see a mmona o di chila mara ha eme bola o bolela sekgoa se seng o bolela le di bombastic words tse ding mara o bjang a monate please a re thusane ke a leboga
thank you number 3 yona. Number 4.
Dumelang batswadi. Bitso la ka ke Josias Matlakeng from Ward 7 Vanderbilt Park. So I'm just going to be straight on my issue, as I'm a sign language interpreter as well. And then I'm leading the organization called South African National Deaf Association. No, I'm familiar and familiated with South African National Deaf Association, but the program I'm leading now under CDBN is CDBN Deaf Association. So my point is one, I'm having a big problem as I was a member of, as I was a part of people who were doing HTC under Gauteng. And then noticing that when you are doing sign language, the people who are doing sign language, normally when they go to the clinics or hospital, they go with their children so that their children can interpret for them. So now, my question is there any way that we can use to try to aloof the situation? If not, come up with a strategy whereby the organization or NGOs that are working with HTC to have people who can maybe practice sign language properly. Because now we are facing a stage whereby deaf people are defaulting because they don't have a clear knowledge of what is happening. So now, if health department can help on that, or maybe engage with different stakeholders to hire maybe a deaf person so that he can teach the people who will be working with. I think it will be much easier in that way because we were 5 in the group, so 2 were interpreters, then 3 were deaf people. So deaf people, the problem was under health department, when they are 3, they only work when they meet a deaf person. And us as an interpreters, we are doing 2 jobs. We are interpreting and we are engaging with hearing people and deaf people. So meaning the hearing people are the ones who are doing a lot of work than deaf people. So maybe if we can have maybe 1 person at the clinic as a deaf person who will be in charge and who will be also interacting and interpreting for those who will be coming there, I think it will be much easier in that way. Thank you.
Thank you. Number 5.
Dumelang, o bolelang ke Phoshi ya Mlangeni from Ward 68. Ka o bereka ke bereka ko Zanimpilo Home Based Care. Mo ke na le complain ya Phomolong Clinic. Most of the time, chronic ba sokella ditlhare. Mo special Severity a se kreya ha ba sitholi la pe clinic. Ba kutshela ukuthi kune shortage ya ditlhare. He ke botsisa hore kanti why ba re fa medication ya o shorta ba re government ya hana tšhelete. So ke yona problem e re na leng yona ko clinicing ya Phomolong. Thank you.
Number 6.
Sanbonane, igama lam ndinguGugulethu wakwaTshwane ndisuka eSidibeni region eVanderbilt Park eBuphilong. Ndiyabulela mhlali ngaphambili negqiza lakhe. Owam umba uzaba mfitshane andizuba mde. Sisixwayiso nje apho kwisebe eli lezempilo ane kukho into eningayiqapheliyo apha eMzantsi Afrika ningabezempilo ningonompilo. Ndicela ukwenza nje umzekelo omfitshane le omncinci. Isebe lezemfundo, Department of Education ane difuna ukuliqhwabela izandla elosebe. Imisebenzi yalo noko ithanda ukubonakala ukwegqitha nina bezempilo besebelezempilo ane umzekelo izikolo ane zakhiwe izikolo and zakhiwa namhlanje izikolo eMzantsi Afrika andithi ilokishi nelokishi I'm sure inezikolo i-primary mhlawumbe more than 5 more than 6 uyayibo i-secondary schools more than 5 uyayibo loo nto leyo andazi uba yenziwa yintoni kodwa ndithi mna xa ndizixelela ndiziphendula mna kukubona ukuthi silisebe lezemfundo umntana uzalwa imihla nezolo eMzantsi Afrika okanye emhlabeni andithi uyayibona so izikolo kumele zakhelwe abani abantwana so nina uxolo uba mhlambe ndithi nina isebe lezempilo dibona andazi anifuna ukuthi liyafeyila uyabo anifuna ukusebenzisa elogama kodwa alinisebenzeli kahle tu uyabo mna pha ebuphilweni apho ndisuka khona anizalelwanga khona nizalelwe eEastern Cape kodwa into eyenzeka phaya not ebuphilweni nje kuphela isidibeni jikelele uyabo iklinikhi yasebuphilweni yayakhelwe izindlu zasebuphilweni izindlu zakudala ezingaphi I think yayenzelwe izindlu i-households mhlambe i-300 and something uyabo sizindlu zakudala lezo ilokishi yakudala bezakhwena nge-asbestos yabo ezo zindlu ezo ngoku kongezwe umvango izindlu ze-RDP zi-7,000 something izindlu ezongeziweyo kodwa kusasetyenzwa la kliniki eyi-1 leya yakhelwe eza zindlu ze-asbestos uyayibona so into enzeka phaa kule kliniki ngumhlola and kukho amazwi avelayo apho ukuthi siyanicela nilisebe lezempilo khanilandele imisebenzi yenu nenze laa nto kuthiwa yi-follow up andazi yabo andiqinisekanga but yilandeleni nenze sure ukuthi laa nto kuthiwa yi-maintenance yabo iyaqhubeka and then isibhedlele sasesibukeni kumhlola ke khonapho andifuni nokuthetha ke ngaso iWoodkop phaya uba ngaba ungene ngoku esibhedlela uzolala khona uncedwe kusasa uyayibo yintoni loo nto leyo ayingobasebenzi nini ngoba isibhedlela sasesibukeni naso iWoodkop yayakhelwe ilokishi elalilidala ngoko uyabo ngoku sekunezindlu ze-RDP ezingapha kwama-1,000 ezongezekileyo andithi but loo nto leyo mhlawumbi andazi okanye aniyiboni okanye niyayibona qha aniyithatheli intloko uyabo bahlale ngaphambili so ndiyalibulela eli thuba mna into endizoyicela kuni makwakhiwe iklinikhi makwakhiwe izibhedlela ezempilo mazakhiwe ngoba ngoku thina ngoku sixabana naba bantu basebenza phaya abasebenzi sithi ngabo ababarhuqa inyawo kanti nabo bajongene noxanduva ubunzima ndiyabulela
2 minutes yawo ifelile number 7 hayi uketla number 8
Okay, dumelang. Ke nna Mpho Sekgotho, ke tswa Bophelong Ward 7, ke tswa programming ya ABCD, asset-based community development. So nna ntho ke tlo e buang e basitse kliniking ya rona ya Bophelong, as everyone ntse bua ka yona a tswang Bophelong. But nna concern ya ka kliniki ya rona Bophelong, ho no ka re ho ka khutla, ho na le program ena no tshwe ke Love Life. So no ka re Love Life e ka khutla ka ga kliniki ya rona ya Bophelong e kile ba teng dilemong tse fetileng then ha isa le yona jwale ene Love Life nna ka ha ne ke kena sekolo e ne re thusa haholo and it thusa youth tabeng ya teenage pregnancy. Ho ne ho dula ho ba le di-session every day ha re tswa sekolong, ho bua ka taba ya thobalano, ka taba ya ho prevent ha banana, ka taba ya ho use condom like bashimane. And ntho e ke elelletsweng ke sebetsa sekolong and ke sebetsa secondary, ntho e ke elelletsweng ha o bua taba ya thobalano le bana ba sekolo ba qazeya ba qaza ntho eo ho usang condom and stuff. So ke nana love life e tlo thusa ka yona ntho hore e be teng, cause ha e ne le teng clinicing twice a week ba ne ba ya dikolong ba lo bua le batjha, ba bua le banana le bashimane, ba gore like ba ba rute ka ntho tseo tsa bo like ha ba tlameha ho be pregnant o le mnyane, ntho tseo tse jwalo. And ke nana hona jwale if ho tlowa dikolong batho ba love life ka hara love life ho no kgethuwa batjha ka hare, ho no thwe ke di-ground breaker. Di-ground breaker ne di ya dikolong ba bue le batjha like twice a week. So ke nana if e ka khutla that program ya bana ho wa dikolong, because hona jwale bana ha ba sa batla le ho rutuwa, ba ya sekolong for ho ja, for shishe, hona le ntho no thweng ke shishe e teng dikolong. Ba yela ntho eo cause kore like ha ba sana interest ya anything ya dibuka ya eng, but ke nana ntho e kgolo ba e shebileng ke ho jola le ho robalana le ho etsa bana, ntho e etsahalang dikolong tsa rona, and ha re tlo e pata. So ke nana if program eo ya love life e ka khutla, ke nana e ka etsa a big impact ka hara community tsa rona, ka hara dikolo tsa rona, because ha se le taba ya secondary fela le bana ba di primary ba pregnant. So ke nana if love life e ka khutla ka hara di-clinic tsa rona, then ho ba le di-session ho wa dikolong ho bana ba bua le ka ntho tseo, ho ka ba betere and ho ka ba le impact e kgolo baneng ba rona. Ke a leboha.
Thank you. Number 8.
Dumela. Ka lebitso ke Hendrik Morwane, ke tswa from organization ba re ke Arutaning Occupational Health and Safety. Di question tsa ka ka sebetse dintshi di lo ba straight to the point. Ne ke nyaka go botsa ka question ya or government e tlo dira bang or di companies dia comply ka di regulations tsa Occupational Health and Safety Act 85 of 1993. And then ke botsa le ka hore herle organization so re ka khono kra thuso ya lena bjang regarding land, because of ka mokho ke ranang organization ke le youth a ke na lebala a ke na tšhelete ke rana di programe tsa ka 00 budget, so ke khono accessa di funding tsa ka mara health. We have programs tse ile re ra di rana, re need assistant ya department as a whole le government leng hape department go tlile bolela hore e nyako partnera le di non-profit of organization tse ile hore di ka thusa batjha ka ho create di job opportunity. So ke re nna re le ROC ke le chairman ya organization, re department re mo re khono partnera le lena so that re khono rana di programme tse re na le programme tse ile hore le rena as organization ra di rana, tse ding ke tsa health, tse ding ke tsa entrepreneurship, tse ding ke tsa di social entrepreneurship. So re hele government le ka re assista re khono partnera le lena ra ka khono create more jobs to barking township ya Atteridgeville ka e ke tlhakele from Ward 72 ke re kopela thuso ya lena re make sure le testing ya thui ya di clinic dia comply ka barking di regulations tsa health and safety. So ne ke re herle batjha so re kopela re le di non-compliance tsa di dumping site tshwantse di checkiwe around township, o tshwana le ko barking this place le mo khoneng ya rena ash ene le dumping site e ntši e irahalang, it must be checked leng hape or office land here le organization so o tshwana le no ke mo process ya o applyela funding ya national notary, but ke a bona ke tsamaya ka process e otlhe ntho e mbantshang ke because of an organization ha ena land ke rana office ya ka ka mara school bag, but di document tsona ba khono bona re ka di tsamaisa. So as a government re kopela assistant ya le ke a leboga.
Thank you. Number 9, ke the last one. Oh, re feleletse boss.
Dumelang le kae?
Re teng.
Le bolela le Moses Selwane mo ke tlhakele mo Ward 72. Ke bereka mmoho le ena colleague ya ka e fetse o bolelang, but anyway o ntshetse di point tse dintsi tse ne ke tlo di bolelang. As young people re na le di issues tse dintsi tse re di identifyang mo makeisheneng a rena. Re kry-a hore yona the very same government I comply le the act tsa health and safety and environment. For example, re na le ho bona hona ko ditleliniking tsa rena re kry-a le hore ko ditleliniking health and safety ai teng. Di-nurse tsa rena tse a di comply le health and safety and environment. Mo hongwe mo ho no latlhiwa dilo tse di sa tshwanelang hore di no latlhiwa mo molaleng. Tse dingwe tse re no di kry-a di latlhilwe. It's a part ya dilo tse re kopanang le tsona ko ditleliniking. Nako nngwe ha re lebella re ira di-inspections tsa rena re kry-a ditleliniki le tsona di bereka ka di-fire extinguisher tsa ho expire. But government e ba yona ne tshwantse e tlhokomele dilo tsa ho tshwana le tse bana ka tseo. E nngwe ke tlo ikhopelang hape ke e a setseng a e touchitse moetapele ka mo ya di-funding. Ra struggle as young people who apply la funding tsa government in this way. Imagine NGOs tsa tshwana le tsa rena di NPO moetapele a ba bolela mo di safarela ho apply la di-funding tsa lena ka tsela e o kry-a le re motho o tshwanetse a tle a na le office. Nna a rena office re operate dilo tsa rena ko ka moreng ya mamang or ka mo bekeng. A re kry assistance from mo lena le government le re thusa hore develop as young people ba re nang le di-organization. So khopelo ya ka ne le hore le lena le government please re nyakeng rena ba re nang le di-organization hona mo makeisheneng, and then le re thuse ka development ka ne ke yona re tlhokang dilo tsa ho tshwana le tsona bo di-office le dilo tsa ho tshwana le tse re tlhokang ka mo di-officing bo di-computer le tse dingwe. Ke a leboha.
Re a leboga. Mereko wa public participation go kry inputs from the community. Rena ba ko health re be re tlhoka di-inputs tse di tsamaelanang le health mara re di kry-ile. Re bone hore Atteridgeville especially ko siteng ya Phomolong ba re ba nyaka tleliniki ebile ba nyaka 24 hours clinics tse di leng mo motseng so that ba tlohele go flokela kalafong, because ha o no tsoga wa tlhapa furugu wa ya kalafong. A ke re le a tseba ne kalafong is a tertiary hospital. Ha o tsoge furugu or ga o na le bothata wa no leba kalafong. Again, tshwanetse o ye tleliniki tla o refera to the level of care ye tshwanetseng mara e seng kalafong. Mme kalafong o ya ka referral letter o referetse ke tleliniki or ke doctor maybe. A ke re a tseba eo ne the ambulance MEC is a problem according to stakeholders ha rena today. Ba re ambulance e tsaya sebaka gore ba ise ko ba tshwanetseng. And then ambulance currently under province, under Maspan. It has been provincialized. I agree, Ranaki, Department of Health go province. So, Negra little say why ambulances are fitting the community because they agree le tembo. The clinic MCHI or Kibuletika or Nauri, Pumulo Kota Sukwa clinic. When you get extra clinic, go pilong, where your stakeholders are not today come. Because community ela increases, generally, palo enchi. Omungu ribile, hunale 7,000, there are new people. Baba Tileng, you need to be creative as a department to go and see how you are going to assist these communities. In the interim, you can start to think about a mobile clinic, because if the community has increased drastically, it affects the services. A shelter is a problem. It's not only the stakeholder, Baba complain anka shelter. Our people ba ema kontle, ba emetse hore ba kgone tsena ka mo tleliniking or ko hospital. Pula ena, phefo e tonya letjatsi le fisha, ene ba tla vroeg mo go senang le safety. O mongwe re ba ema ka 4 o'clock. So that it means batho ba rena ba nyaka go berekisa di-services ene ba di thabela di-service tsa Department of Health mo Gauteng MEC. But the issue ya shelter tshwanetse addressiwe. You need to go and be creative, Mr. Kobo, and the rest of all of you. How are you going to address gore batho ba se tlhole ba ema ko ntle mara ba ya go tsena ka mo tleliniking go sena shelter, go sena protect safety? I get a safety. If we eme ka 4, you want to be number 1 ge tleliniki bula ka 7 or ka 8. Mara a gona gore a gona mo kore you are not safe, you are at your own risk. So go and be creative. Rena as committee here, we encourage you to go and be creative. Come out with how are you going to solve problem ya shelter. Go tloela re bone batho ba eme ka line di-taxing dikoloi di a feta and a go safe. Health inspectors, I'm not sure if Lisa exists at MEC, because community e leng mo stakeholder se complain ka dijo tse e leng gore a di right ko di-spaza shop. Where is our health inspectors? Ra di nyaka di bereke, if a di teng, let's go and revive it. Kale the health inspectors were all over. Ba tsamaya ba check. Re bona mo di WhatsApp group go na le batho ba ba creatang di food stuff. New HOD, welcome. Ba create the food stuff in a certain space, then they go to the spaza shop. They don't go to town to go and put them in ShopRite or wherever. Marabaya Ko Township, our people are exposed to rotten food. Your health inspectors, tshwanetse ba be active now. Kuri is chance for them to be more active, to make sure they remove those foods. And I don't want to be sounding biased or not xenophobic, but it is mostly people from outside where I have seen them creating this kind of rotten foods or illegal foods that are not tested in the form of tin stuff and other stuff. And then the issue of the medication. It is also important maybe to decide as a department, how are you going to control cough mixtures that is being used? Is not only the stakeholder that is raising it. It is very important for the cough mixture. Perhaps you can contact SAPRA. I don't know, but you need to come out with something. As Gauteng Health Department, what are you going to do about it? Because it was through the counter. You don't need any prescription, but it's being used as an addictive, especially, yeah, I think, let me just say cough mixture. And then teenage pregnancy is a pandemic in our country. Yes, and 9-year-old or 12-year-old that are getting pregnant. As a health department, what do you do if you are a CEO, Dr. Majila? 9-year-old, it's ipepe. How? How is a 9-year-old going to take out the baby through the vagina? In the middle of the night, you must now sign for a cesarean section. And then we are quiet. As a community, we just say, "Batla ipona." It's about time the health department, together with the community, to make sure that the perpetrators of this teenage pregnancy are getting arrested. I was shocked. I was teaching somewhere in a university. I happened to teach a PhD student who was doing this issue. Then I learned an 18-year-old was having 9 children. I was like, how? I was like, wow. But then it's a problem. This community, this stakeholder is raising it as a problem. As health professionals and workers, time to be ignorant should go down. I'm going to hand over to MEC and the department to respond to those issues that you have raised, particularly the issues that are related to health. Those issues that are related to like your land and what have you. You can come in front here, your issues of drugs and what have you. You can come. The HOD is here, Dr. Nolutungu will come and will refer you to these officials so that you can go and see the right person to help you, because they are here as health professionals and health department, but they will help you in terms of your reference. But these stakeholders has made its voice heard. They want a clinic in Bupilon, they want a clinic in Pumulong. They want 24 hours clinic. They want you to go and sort out that ambulance that you, department, you made it provincialized. So you must go and sort it. They want you to go and make sure every locality is having a health inspector to go and fix. We don't want people who sleep in one shop. They sleep, they sell paraffin, they sell food in one clinic. They also use that area as a toilet. This is embarrassing. We can't have these kind of things. Perhaps we must also address the issue of indigenous medication. Thank you. MEC, over to you.
Thank you very much, Honorable Chairperson. Maybe ke arabe ya ko bophelong because ke a e tseba and ne re sentse re startile ka yona. Okay, thank you very much. Kere maybe ke starte ka ya ko bophelong before ke fa HOD sebaka sa go bua. Clinic ya bophelong bana beso ke deployile ko bophelong ka parliament. So re ile ra ya mo ra checka ra bona hore ka nnete batho ba queue ka ntle, batho ba baholo, basadi ba pregnant, clinic e nyane ha ona space. But ha re checka just across the clinic hona le ntwe ka reng police station akere. Dr. Maseko ka nako eo as the head ya infrastructure o ile a bua le municipal manager Tate Leseane hore ho ka ba jwang hore re kenye the park home just across the clinic because hona le space se sengata ha o ka checka police station e mo and then ho ella kwa hona le space se sengata. So that was before the election. So hona jwale Dr. Maseko ha sa le teng, Mr. Kobo o tla tshwanela ke hore a e latelle because akere ke land ya masepala. So that was going to be a temporary measure whilst we are still waiting to build a proper clinic. And really ran sa le ditulo as PCO hore at least ha batho ba fotse ka ntle ba be le mo ba dulang. But itse ha re ya hape ke lo etsa assessment ka thola hore ditulo tseo ha di lekane. So that would mean hore we need to fast track process ya ho lokisetsa this structure se seleng across because it's just across the clinic. Jwalo ka ntse le bua batho ba rona ba tswang bophelong. So ke tlo fa HOD opportunity ya hore arabe hona le mme a raising the global issues. The fortunate part of it ke hore our HOD ile HOD mona before atla ba health attaché ko US. So o tlo re thusa hore jwale ka ntse a sebetsa le mafatshe a kantle ho etsahala eng ke eng e re ka improvang as South Africa and the province hore etse hore re improve maphelo a rona. So ke tlo kopa bo Mr. Kobo le bo Dr. Khongwana and bo Mutaletale in terms of the strategy ya design language and so forth, so that le khone hore le arabe le lona, but re tlo starta mo re respond and then we'll give you an opportunity wherever you are to respond. Thank you very much.
Ngiyabonga MEC, Honorable Chair and honorable members of the committee, my colleagues. It is encouraging for me now to see a community engaging actively as our department presents a way forward or the plan for the year. It means Khuri, we are all interested in this thing, in longer, healthier lives together. The question is, how do we get there? And the communities rely on us as employees of government, as civil servants, to assist us get to that point. So this engagement is important for Luna. Oh, okay. Le engagement ibalulekile kakhulu ukuthi masibuyele emuva ema-ofisini sizabe sicabanga sabe sicinga ngobubuso bebulapha ngalamazwi abekiweyo apha ngezi recommendations zibekiweyo apha even noma i-plan ikhona that all of that is to enhance the work that we do. So ngifuna ukuthi chair siyabulela nge-engagement and active participation yale community kule discussion. I-colleagues zami engihamba nazo because mina this is my second week at department. They have banawo ama-detail responses to some of the questions as buziwe. Bazoncedisa ke in some instances ukuphendula if you don't mind, but at this level kule view ndisenayo ngokwangoku as coming out of the discussion this thing here, youth and adolescent friendly services. Youth and adolescent friendly services ikhona pha ku-APP yethu. In the last kwezinyanga ezidlulileyo zimbalwa benisebenza emaklinikini e-Deep Slot, benisebenza eThuyaruna clinic. Masimejara izinto ezenzekayo lapha yanekliniki. Kunenye indicator ethetha nge-youth and adolescent friendly clinics. Abezi, young people don't abezi a clinic, and those clinics are actually supposed uba zi-ownwe ngabantu abancinci by the youth. There should in our clinics be a section where they say, the youth say, to the clinic. Siyawazi ama-challenges e-communities zethu. The young lady here, I forget her name. Yes, Chair. Where's analendaba ye substance abuse? Teenage pregnancy. Teenage pregnancy is basically statutory rape. Things that we need to deal with it like that as we address the relevant social issues in that context. So, Youth and Adolescent Friendly Services Program. Sizoyijonga carefully, and we need to see young people in place sitting at the clinics. Bangaphuma esikolweni mhlambe ngama-holiday and they occupy space at the clinic, working closely with the sisters there, but informing us on the program as aba relevant kubo as they experience the issues relevant to that. So I'll be looking carefully into that particular program. Another experience that I had, many people bayiraisile le question. Emma Shelter, MEC, now you did refer to that. I think the chair also referred to that. Shelters, as people clinic, I have seen it. It's a painful thing to see. I think Mr. Kobowin really needs to do something to be innovative around how we deal with that question. It's an important issue that we will take forward and see how we deal with it. Indigenous knowledge system, that is important. Uzothola ukuthi namanye ama-medicines abo-offering laba igazi libe lingakloti ziphuma emhlabeni. Most medicines are from what is called medicinal plants. And I'm glad to say that the National Department is working hard namanye ama research institutions Almost CSI areas, there be big unit lapayana, esebenza nge-traditional medicines. Manje, MEC has just appointed a representative, province, to the National Council on Indigenous Knowledge, who will take the issues from the province to a national level. So ISAPRA and National are working on those issues. I think we have a government that is very progressive in that regard. So we are hoping to be seeing progress soon in relation to that. EMS, again, it's a personal experience. Someone also from the floor are raising personal experiences on this thing. We are at a clinic, there's an emergency. You wait and wait and wait for an ambulance. For about 4 hours, the ambulance I think. Sometimes they call, no one is picking up the phone on the other side. MEC was sharing with me that she tried it now, she had the same experience. So it's a pressure point, it's a serious pressure point that we will take forward to sort out as the department. The issues relating to Ibo Pilong Clinic have been adequately addressed from where I am sitting, and I think we will work with stakeholders in that regard. So these ones that I've mentioned so far are the big ones for me. Basically because as the details, my colleagues will assist me address. So I am here, it's my second week. I'm listening, I am learning, but at the same time too, I am expected to move with speed to deal with these problems. So that is what I am here to do. Thank you for the opportunity to respond, MEC. And thank you, Chair. So I'll hand over to my colleagues now to assist with some of the questions. Ngiyabonga kakhulu.
Thank you, MEC HOD. I will respond to concerns that were raised by Speaker number 1 on the budget returned to Provincial Treasury, Speaker number 3, and also Speaker number 11 on the procurement of wheelchairs, and then Speaker number 12 on unsolicited proposals. Number 1, maybe let me just respond in saying, yes, there were funds that were returned to the provincial treasury. As of last year, we had a budget that was preliminarily allocated to the department for an amount of 56.5 billion. This amount was increased to 59 billion during adjustment, right? So when the year ended, 2021-22, we had spent plus minus 95%, 95.7% to be precise, of that budget. And there was about 3 billion that was not spent in the year. But if you look into areas where we had underspent, we paid salaries of employees as we were obligated to. We spent money to procure goods and resources, goods and services as we were obligated to. We transferred funds to NGOs and NPOs as we were supposed to do. We also spent money on maintenance and also refurbishment of infrastructure. By year-end, infrastructure had spent about 82% of its allocation. And then we also spent money to procure machinery and equipment. But of course, there are invoices that were not paid by end of the financial year, and those we regard now as accruals. So those accruals are now transactions based on services that were rendered and could not be paid and accrued into the new financial year. By year end, we had accruals of 4 billion. And remember I said we underspent with 3 billion. But within that 3 billion underspending, there's about 1.5 billion that related to conditional grants. And remember, conditional grants, as and when we underspend, we then have to return the money to National Treasury. But we have subsequently requested rollover because we had projects that were committed during the year and the money is now requested for rollover into the new financial year. So it doesn't mean that when money is returned to a provincial treasury or to national treasury, it means it's underperformance in terms of service delivery. Services have been rendered and some of these monies will now need to be continuously used in the new financial year. Do you understand what I'm saying? Covered. So, Speaker 1 and 3, I hope I've responded to your concerns. But if there's any follow-up, then please put that in writing. With regards to Speaker number 11, yes, it is a concern. It's something that government has noted, that a lot of our black-owned, especially black-owned, let me say, companies have been defrauded. So when you receive an order, you really need to check as to whether that order is valid and legit. So sometimes they use information of employees of government, but not necessarily the actual address. The one thing that you will pick up is that the address in terms of the point where you're supposed to deliver the resource is not necessarily a government-owned structure. They will tell you to deliver material maybe in a normal street or in a building that is not even related to Department of Health. So we want to advise our public members that when you receive an order, please check. Rather call the department on the toll-free number that is allocated or that you would have checked somewhere for you to confirm as to whether that order is legit before you start delivering goods. Many people have cried, a lot of companies have been robbed of money, but it would be an order that is not legit as such. So we would encourage you to rather call the department and ask if the district or the hospital itself has placed the order. We helped a number of companies that made such inquiries in the past, and we are still prepared to help. With regards to unsolicited bid, I would encourage you to please make reference to Practice Note 11 of 2008 and 9 as issued by National Treasury. Government is given a framework on how to address unsolicited proposals. So Rona as Gauteng Health, we are also making use of that Practice Note. Literally it says, as and when you bring in a proposal, we first need to check as to whether what you are bringing is unique, is innovative in terms of the business that you want to bring to government. Once that is now identified as a unique and innovative project, we will call you in to come and then discuss the business plan. We will address that issue. From that particular point, we do an RFQ or an RFP. So an RFP will then invite the public to determine as to whether we can then look into that particular project. Obviously, it's your idea. It has to be costed, but it also needs to show the uniqueness in terms of its proposal. So I would encourage you to basically look into the framework and look into the process that government is engaged into in terms of unsolicited proposal or bids. I hope I've responded to your concerns. Thank you.
Thank you, CFO. I hope that answers some of the questions. MEC uyangikhumbuza ukuthi I was supposed to respond to the question African Union. Yes, this lombuzo speaks to a question of a global view. It is more of a political question than it is a public health question, but ngizozama ukuyisondeza to the public health question. In terms of global health, uzawuthola ukuthi the continent's approach to public health is driven kakhulu by primary health care. Kanti, if you compare with the other regions in the globe, it's mainly hospice-centric. Maybe it's because of i-burden ye-disease ezingafaniyo, izifo abahlangana nazo. Uzothola ukuthi thina lana sidila ne-TB which is spread in the community, sidila abantwana kakhulu bahlutshwa yi-diarrhea which is spread in the community, abantwana bahlutshwa yi-pneumonia, kanti abantwana kakhulu ngale izigulo zabo akuzilezi zase-community. So thina kumele sithathe i-primary healthcare approach as a region, as a continent, as we deal with public health. So from the perspective of global health, that is how we differ. But the African Union is sensitive to those issues. Recently, kuye kwasekwa i-Africa Center for Disease Control. If we are back lapha ku-African Union, ama-diseases akwi-list ye-CDC ye-African Union, in terms of the causes of ukugula and death, as far with other continents. So we are tackling it from that perspective. And we rely on internal resources largely to implement those programs. Of course, there will be collaborations with the superpowers of the globe to assist us here and there. But as we engage those superpowers, we direct them to assist us deal our problems, not come and solve our problems for us, but deal with our problems as we understand them. All of this is at the level of national government, not at our level here. Of course, we will give input to say, this is the experience on the ground, and then national will take those experiences to negotiations at global level. That is to the extent that I can address it, MEC. Thank you, Chair. May we ask the APP lady to assist?
Thanks, HOD. I'm going to respond to, ke tlo responda ko di questioning tsa ICT. Question ya mathomo e botsitsweng e ne le question relating to forensic information system. So we must remember here hore forensic e deala ka dia natural deaths, ne? And these are natural deaths di ka occur anywhere. Hospital, maybe somebody who is hospital, committee le society, that person must eventually be taken to the forensic mortuaries, or maybe motho o fihlotse mo strateng a shwele and all those kind of deaths, ne? So the information system e re developang, it will make us sure gore khona go recognize gore batho ba ke bo mang and what is their medical history. And that medical history, we can check for it ko di dipetlele tsa rena. So the health information system e re implementang ko dipetlele ultimately is going to be linked to this forensic information system. So in our enterprise architecture, or I guess I could say enterprise architecture ka Sotho ke, but basically go na le a layer in that architecture, like how a ga ntlo go na le different layers, different things, different components. So in that enterprise architecture, go na le layer ya exchange. Exchange layer, it helps us go kgona go kry information from other organizations or other areas. So how we're going to link with the hospitals and the mortuaries is through that exchange layer. The second question that related to ICT, it was referring to the downtime, like about ba ya ko di petlele or di clinic ba fitlhela gore maybe system ha e bereke ba re ba khutle ning. So one of the things that re di dirang re bereka le department ya rona ya e-gov is to explore happy the use ya the solar system, particularly that we are experiencing a lot of load shedding, matsatsi a. And HIS, the way it's set up in Gauteng, it's got a primary link and a secondary link. So in case the primary link your system is failure, you'll still be able to connect onto the system using the, the secondary link. Another question, it was relating to issues about pele and also accountability within the system. So please be rest assured, the department is doing all in its power to make sure we comply to Batupele. And that is why every of our facilities, we've got not only the Batupele, principles being complied to, we are also encouraging the charter, because ultimately healthcare provision or healthcare, it's about, it requires participation here, Luna, as well as communities. So in those charters, we are outlining what is your responsibility, in terms of health, and what is the responsibility of the healthcare provider. Because a lot of times, I think we've gotten to instances where maybe like EMS personnel baba raped. So how about raped vele, so in such instances, our community, how will they help us to make sure that we provide, proper care? And those things, dingwadi more chatting. And during the open day, clinicing, we do communicate about performance, the health, the hospital or the clinic. We also give information what are the commitments fulfill. So over and above those open days, there are structures in government. We are here at the legislature. This is another structure. We come and account to you through this particular public representatives, as a legislature. We also do account during the IMBI, so if only the IMBI, so in the communities, we can give account, how did we, make use of it. Thanks, HOD.
Thank you, Chair. I picked up a couple of questions on Bupilong and on Eersteres. Yes, I'm asked to introduce myself again. My name is Sandani Kobo. I'm in charge of infrastructure at head office. The items I picked up was on Bupilong and in general the shelters, which was a welcome a suggestion from the chair as well as the MEC, and the issue on Eersteres. Let me start quickly with Bupilong, which we talked about a few times. Yes, I am aware of the problem with Bupilong. I was there in person. The problem is not only that the clinic is small, the yard is very small. When I joined, I was told we need to extend. I went to Bupilong in person. I know the area. There's only half a meter from the wall of the clinic to the fence. So that is the problem. So I welcome the inputs from the MEC and the chair to say we really need to think outside the box to say what do we do in that situation. The other solution, of course, is to go and build it elsewhere. But from my experience in other areas, then the people, the local, the original Bupilong people will say, no, the clinic is too far. So we are going to have to look at other solutions, mobile clinics and so on. I was very tempted to even close the road, ask the municipality to close that big road in front of that clinic to use it elsewhere, but it's not within my power. So we are looking at that. We'll take in consideration the inputs which were raised by the chair and the MEC. In terms of Eersteres, the lady mentioned something which I picked up as I take these forums as not a place where you come and give excuses, but rather listen carefully to say what is required. She mentioned that we need to concentrate on building this clinic, Yersteres. I know where she's coming from because we already sent a contractor to that site to build this clinic. And the local business forum fought with the contractor. The contractor eventually gave up and left. We are going to get another contractor, and we are helping we are asking the community this time. You heard our sisters saying and our mothers saying, let's concentrate on building this clinic and not other things. Those are the issues I picked up. In terms of the rehab facilities owned by the municipality, we'll be talking with the district management to say how can we arrange for that, but because that is not such a difficult thing to do, as long as it's within our mandate and the rules within local government and central government. Those are the two I picked up. Unless the other things I missed, I can be reminded. Thank you.
Okay. Ke leboge baeteledipele ba rona, ke lebogele setšhaba sa rona. Ke tlo simolola ka go gatela ya batho pele. Ke bona there is Peli FM le Commuter FM. Re tlo kopa tšhono ya gore re tlo bua gore setšhaba sa rona se kgone go utlwa le ba ba seng teng ka mo olong ka kgang ya batho pele. Mara ke kopa go le joine di clinic committees le di hospital boards because le kgone go re thusa ka gonne setšhaba, you are the mirror ya rona as healthcare workers. A ke re ba re o motho ka batho, re rona ka lona. Izandla za gezana. So re kopa le ka di ideas go re thusa. Now, ke tlo simolola o se le ka mme o la a reng na ba le ko Samesi e thwathwa isala HOD then are one of the doctors a bue le wena go follow up on your problem. Ke kopa gore o ikopantshe le nna today please before ke mme a tswang Vanderbijl Park wa SMME. Ke mme noise ke kopa re kopane because re ready follow up because we will raise the issue gore as health are ready follow ups. So ke kopa re ready follow ups ba ke kopa ba gaetsho le re gopotse le ska re ngala. Little proposal, hey, by the way, we told you this, or we complained about this, or we came with this kind of idea. How about it? Kanya Pomolon Clinic mo hosnan simvastatin, where the medicine simvastatin and a new Yersteres clinic. Nadema kudu ute, incompatible kudu misel zoho, ki the director primary healthcare services mo Motswani district. Kikopaleko pansili enatle. But I get with the Renata de Makudu with the Roro would like follow up can you Yersteres li issue or Hoshota di go Pomolo. Le any other problem. The NGO Saruna, our youth, Baba William, they have this idea on occupational health and so on. Kekopaleko Panselinda de Makudu so that we can have that collaborations with our communities. It would forget Dr. Machile. Uteng ka issues tsa kalafong ke the CEO a ke tsore tshito o tla araba mo Dr. Machile ka ilo tsa kalafong so ilo tsa kalafong re tla di tlogela Dr. Machile a di arabe issue ya pharmacy e botlhoka tota because a re batse di line tse telle tse ma Dr. Machile o tla araba mo go yona issue ya mammogram cancer ke tlhoba boroko. So re amogetse re tlo dirisana le yona HOD wa appointile a task team ya dila le cancer mo Gauteng ke chairperson ya yona ke tšhono. It's an opportunity and a privilege gore ke dire le the cancer license. So re tlo buisana gore how do we get what we call pink drive ke an NGO ena le the mobile mammogram trucks ke itse Josh Mukareli bo Jubilee ke le ba di berekisa in the past. So, the ideas, my little number to send the ideas, how do we do it? Because I a lot of pressure also on Kalafong, but those are some of the ideas for batho ba bo rona bo mme re kgone ho dira di-mammogram, including cancer ya cervix, including bontate cancer of the prostate. Are preventing, but prevention is better than cure. Ke kopa le ska ba le ditlhong, le ska tshaba. Yeah, EMS, I think that the reiter o ile a bua ka di-ideas tsa ile di share le nna HOD. Ke kopa gore a di tlise a tlo share le batho ba rona, what are they doing to improve the turnaround ya EMS? Ke Sikhokho sa EMS na director reiter and ona le di-ideas. Substance abuse, ke tlhobaboroko e masisi tota. We have to work together. Re na le di-meetings gone jaanong le social development. And one of the things re raising gore re berekisane mmogo ke gore re tle ka di-ideas or how do we reduce substance abuse, nyaupe, patje or whatever. Ka gonne re deala le congestion, go tlhakatlhakana ko casualty, not because batho ba na le bolwetse ba tlhogo, mara ba tsubile or ba tlhabile or ba nwele. A kere gore go na le ba mixa ginger ale le something hona banong le spirit or something like that. So are dirisaneng di NGO tseo are kopaneng re kgone bua le mo Peli FM le Commuter FM gore are dirisaneng mo go ba gaetsho re sonzo re ifeng ntwe re kgone go fenya apartheid. I don't think tla re palla nyaupe ai ka se re palle re tshwaragane re le so re le some so-called ne. So re dirisana mmogo mo departmenteng le bo Dr. Sibeko ke head ya rona ya mental health. Re kopana le what they call the mental health advocacy groups ba re dirisana le bona gore a re tlenga di-ideas tsa gore re kgone go fokotsa mathata a mental health mo dipetleleng tsa rona, especially go ba le mepeto ka re o kry na le problem ya gore a rena mopeto. So ke something e re kgatlhana le yona gore kgone go resolve bothata ba gore go ska ba le mepeto ya accommodate batho ba rona ka gore la itse mo di-casualty gore go tletse and go tletse batho ba rona ba na leng bothata ba tlhaloganya. Re tshwanetse re berekisane mmogo gore dikereke dikolo ka fela rona re disane mmogo gore re lwantshane le roborobo le la nyaupe. Mama o lle ke another pandemic, a re lwantsheng pandemic eo re e fenyeng. Issue ya waiting time ke bothata gore batho ba ema sebaka se se telele. Ke kopa le ska ya ko Twitter ka gore o kry ya ko Twitter or ko Facebook o ntse o le mo sepetlele ke ntho re kgopelang. Of course re na le freedom of choice a kere freedom of speech, mara ke kopa ke eletsa ba gaetsi gore ha o na le bothata mo sepetlele kopa clinical manager, nursing manager or CEO or ke gale ke eme mo go etsagala eng so that ba kgone resolve a problem eo. So mara le na di rights a kere ba gaetsi ya go itlhagisa ba nna ke kopa gore ha o le mo sepetlele o ska tshaba gore o bua le ke yona batho pele principle redress courtesy and o bue le ntwela le di-managers gore ke na le matsapa ba gaetsi ke kopa le insolvele yona tswetswe. Go na le me a raising issue ya termination of pregnancy ya di medical abortions. Ke kopa le yona le ska tshaba go itlhalosa if le kopana le matsapa mo districting ba tshwanetse ba ya amogela gore re kgone go dealana le yone issue ya termination of pregnancy e dirwang not go a ke le tlhole bona di-posters tse reng painless abortion. I think painless abortion yo and e go painela mo tlhaloganyong mo moyeng le mo pelong le mo mmeleng. So ke kopa le ska tshaba ba gaetsho and re kgone go tla le mo Peli FM le mo Community FM re tlhalosa gore go diragala jwang. Go na le matsapa of course a re perfect a re lo go le fora re iphitle ka le tlhokwana. Go na le matsapa go na le mathata mara a re tshwaraganeng re rona ka lona ba gaetsho. Na ke bua le ntate Rakgwale mo ka issue ya food inspections. Most of the food inspections di dirwa ke municipality, mara ha o pale gore rona re bue le bona ba gaetsho ba municipality gore please oketsang di food inspection. Ka itse gore re na le environmental health but ha as strong as environmental health ya municipality. Ke bona ba fang di licenses but re tla isa molaetsa ko ba gaetsho ba municipality gore se believe talk how go be le that inspection. Tirisano mmogo tshwanetse no ba teng ka dinako tsotlhe ke some so-called ba gaetsho. tla ke check gore a ka tlogela next go araba ba gaetsho. Okay, thanks HOD, thanks MEC, Chairperson, ke a leboga. Dr. Machila, Mogaetsho, atamele.
Dumelang kaofela ke Motalata le Modiba. I think Dr. Khongwana o fetsang ho bua o boletse ka ditseng ngata tse leng hore setsa di arabile ke tlo araba A1 fela e bolelang ka taba ya sign language. I think ki suggestion e pile e tsuleng around the issue ya sign language ke ntwe leng hore re tlo lebelisa re bona hore through our training unit re khona hore re address re khona train our frontline staff or at least ba be le di skills tsa ka khona ho communicate le batho ba batlang go di facility tsa rena ba ileng hore ba tlhoka hore re bolele le bona through sign language. So we noted it and immediately we will be escalating it so that it can also be included when we roll out our training tsa staff sa rena, because I think constitutional rena ya bolela e re tshwantse re khona hore re communicate le batho kaofela ba batlang to our service points ka tsela e leng gore ba khona go utlwisisa se re bolelang le bona ka sona. So re noted that thing, we will be addressing it. Thank you very much.
No, ke a leboga Chairperson MEC HOD community ya Mopeli. So we welcome these engagements. Actually, any platform re bring together with community go bua ka ditirelo tsa rona ke platform re welcoming as the hospital. And I think as the hospital we've tried to make ourselves accessible to the community through various platforms. Renal partnership right le Peli FM. From time to time our staff buy ko Peli FM to try and educate the community on a whole lot of different issues. Tse di etsahalang ko sepetlele, about medical conditions and all that. Hona le dibuledi tse 3, I think Councillor Pasha we listen to are hona le with a system overload. And it is true that we are inundated ke balwetsi re na le increased patient load. Ele rona ere ha re lebeletse and we trying to push balwetsi ba rona ha re busi molwetsi ko kalafo. And we are also aware hore balwetsi ba rona kana go batla ba sna di referral letters and ba demanda ho boniwa. And ra ba bona. And we are always trying to explain hore re na le lower levels of care di clinic tsa rona tse di ka berekisiwang. And we try to educate. But because remollicationing, right, it's easy to tla ko kalafong. Re na le Pretoria West, which is a district hospital. But ba rona ba mo Atteridgeville ba prefer ho tla ko kalafong. As management wa ko kalafong re lebella dilo tse re ka khonang ho di etsa. Tse di tlwetsang hore experience ya lona e be betere, improve. Me Adelekan ubuile ka the health information system, because one of the speakers ubuile ka taba ya wemela di file. So re tshepa hore ha ba implementile the health information system, ho tla ba easy ho kry di file. But le rona as community we must also play our part. Re start ko di clinicing re tle re kreile referral letter ha re tla ko sepetlele re booke. Khona ba nko sepetlele re bua ka ho buka. But we also know hore ha re bookile molwetsi a rona ka tseno o tla ka moso. So ha re bookile batho ba 100 ka tseno ka moso ho tla ba 50 ba ntse re ba bookile mabane. And then the next thing re na le balwetsi ba 150 ba ntse re sa ipreparela bona. last month, Karnele April, national holidays. So obviously, because holiday Wednesday, then we make up for the Wednesday, then we end up having the other days because we had shorter weeks. Then our clinics were full, our pharmacy mainly, because I get all the patients battle from different clinics. And we have those who are on repeat medication. Renali system hape mo Department of Health re bitsa Ccmdg. Ya hore re ka isetsa batho melemo ko gae. But you have to qualify, re-enroll abalwetsi ba rona mo. So renali all these things that we are trying to put together as a department and as a hospital. Ho try hore re reduce waiting time, hore experience ya rona ko hospital e be pleasant. Dilo tse ding tse di ka se bonagale like maybe gona byanong hore impact ya teng le ka se feel gona byanong, but hanyane with the little improvements re di etsang in the system ke na le tshepo ya hore le tlo bona. Mainly with our pharmacy anyway, we're trying to look at our booking system, look at a whole lot of things that would improve at least the queue because that's our main pressure point, our pharmacy. And Rautla, we welcome the feedback that and I'm going to take them back to the hospital to say community arona inali problem area we also would like to advise, I think, but to hore accessible. So how hona di problems nyane, like let's say okospetlele hona le bothatanyana bo bolenteng. You can actually speak to like Dr. Khongwana Abuile. Renale quality assurance office, renale the clinical managers, renale nursing managers, renale na as the CEO. Ke so engaged the community arona to an extent that some of the people bang Kitsukare we've actually met, because I even respond to messages because renale Facebook page yakala phone, so renale this messenger, and I've seen that a whole lot of our people use messenger a lot. Haba butsaka bo di appointment, haba batlo move di appointment tsa bona and all that, and we engage there relevant departments. So we are accessible. Halinale matata, you are welcome to request for officer manager, and we will be able to help. We will be able to assist. Nekutla bar honali issue security, which I didn't quite understand. Renali problem ya batho ba phakang ka montle o kra ba ba thwetse dikoloi and all that, re-engage maphodisa gona ba non le CPF ke problem e beyond hanyane the hospital, but a re tlohele fela because I kere ke balwetse ba rena ba batlang ka mo sepetlele. But then we welcome the councillor ha le na le mathata le ka bua le rona. Obviously I kere la itse hona le the way tshwantse re engage ka teng la itse a kere ho ba provided for if ever le batla ho bua le the proportional representatives, le tshwantse le bue le bo medicamela and then HOD a ba re instructor. Because kana kongwe community o kra ba no tla ko sepetlele and ba demand ho bua le management. So rona re accessible, and we are working very hard, and we promise the results le tlo di bona ka di measures tse nyane tse re di implementa. Ke a leboga.
Thank you, MC. Dumelang. Ka leina ke Ruben Reuters wa director ya EMS. Re utlwe dillo tsa di ambulance. Ke ne ke re amogela gore re itlhalata. Kana go ngwe re itlhaile gore nako e hitileng int. Ke ne ke le ke go tlhalosa gape gore batho ba bentsi gona jwale re berekisa di cell phone go bitsa di ambulance. And pele re ne re berekisa telecom lines, re ne re founela 10177 akere. No se re founela 112 ka cell phone. So pele ka 10177 ga o no phone
and it's not directly mo EMS office in Zarona. Bianong ichinchile kona national number ibitswang 112. 112 number iyako officing esing ya rona. Baya batsa details tsa batho and then ba transfer la khole ya gago mo go rona or to any other province. So it costs also a delay more. So can give power learning re bereka re department of communication go re thuse go re change how phone o bole rona directly go ska nna le middleman mo gare. So can ke tlhalose eo re ile ga lemoga a re sheba data ya rona gore re ka improve yang service ya rona. So re lemogile gore as re dirisa 112 rotlhe di clinic di dirisa 112 ga ba re founela di patala di dirisa 112 ga ba re founela le community setšhaba. So o fitlhela gore go na ne too many calls kenang and other people are holding too long. So e re dirang gona yaanong re splitter di service tse kaofela gore community e be line ya bone e leng 112 bone ke national number le di ambulance tsa bone and so on. Di clinic le bone ba tla le ipatala ba tla ba le number ya bone gore ba ska bana le tiriso ya bone as di clinic le di patala. Re busy re ntse re change and re improve more. Engwe e re dirang gona yaanong ke go beya di toll free number mo di ambulance tsa rona gore if batho ba rona ba abuse di ambulance ba se di dirise sentle community gone go engage e re itsise re gone go addressa so that because leone ira gore di ambulance e be delay ga tlhokagetse mare ya botlhokwa e leng gore ile ya amiwa ke chairperson gape mo le HOD ke taba ya di paramedic attacks brinkuwa powo at gunpoint ba bang ko Atteridgeville ko bo Alex while treating the patient motho wa tla ka sethunya mo ka thipa ba tsa batho ba gona powo and batho ba gona le bone ke batho le bone ba tsoga ga ba nkuwa powo mo immediately area yeo e tla sifaiwa as a hotspot maponisa tshwantse a tsene mo tshwantse ga re tsena le gona mo go na le kholomo re bele maponisa a fitlhe a re escort ra itse maponisa le bone gore bana ne mereko wa bone ga ba re fitlhele at all areas ka nako le bone. So all those things they contribute on our delays. So re a gopela gore as lona re improve ditshebetso tsa rona re gopela shaba le gore le CPF gore re thuseng gore botsotsi le bone re ba bone ba reportiwe ko maponeseng ba tshwarwe so that rona re gone go fitla ka nako mo ke leboga actually. Thank you.
Thank you, sir. That was the last one, Chair. Thank you. Re a leboga Department of Health go responder under the leadership of UMEC lo nna le rena until now. Re khupela tshwarelo gore re fitlhile ka nako e late, but we have already sent message wa complainer ko legislature because re delayile ke legislature for gore lena le fitlhe mo ka nako. Nkebe re startile exactly ka 10 hantši ka 1 re feditse and then re kry-a dijo ba bang and then re tsamaile. So ke khupela tshwarelo for tabeng eo ya gore today re startile lata re ke re starta lata rena. And then ke a le leboga gore le raisitse di questions rena as committee re tlo follow up di questions le ka mokgwa ba promisitseng gore they will deal with the issues. A ke re ba ikanne mo pele ha lena they must go and create family planning mobile clinic go fokotsa teenage pregnancy. They must have school health services go fokotsa di problems ko dikolong. So bana ba banyane ba bo 12 years ba pregnant ba bang they don't even know lore ba pregnant. So the mobile clinic di ka thusa go reduce some of these problems because infrastructure le yona it has got a lot of work. Department of Health relies on Department of Infrastructure for the new buildings and including maintenance of the health facilities. So, but mobile clinics and Tatekobo, mobile family planning clinics can be helpful. All our schools really, they should be visited. Ka health education, it will work. I still remember the old health education that I gave when I was still a young training nurse. I still remember what that nurse told me in my school long ago. So it will work. Working together with our councillors, will also help us. Indeed, it's true. These people, they attack our paramedics. So we must work with our local police station for assistance in certain things. SAPRA, it need a visitation between Department of Health and the National Department of Health. They are Gauteng, where they deal with the issue of tobacco, because we benefit the multinational companies more than our people, but it's our people's health is affected. Ke rata go tšea nako e ke leboge honorable members that are here with us today, and I know Member Mabunda had a commitment, he left. But I thank you very much for staying here and listening to the community, our stakeholder from the whole province, and they raised genuine concerns and they should be addressed. And I thank you, our stakeholder, for coming the whole day and listening. We listening to what you are raising. We are with you, we are representing you. We will ensure that all the issues that you have raised, they are going to be addressed. The lady who are raising Tabaya right to care, you come and see me, I will make some contacts for you. And the Department of Health under your steward leadership, HOD doctor and MEC doctor, thank you very much for coming with the entourage. And Councillor Masuku in your area, we thank you for allowing us to come and be here. And we are safe here in this area. Agona corruption, agona ditsotsi a di go ka mo Ntate Khobo re safe. Agona di ma security mara mo Atteridgeville mo re leng mo re safe, so re a leboga. So public participation e tlang, we will make sure gore re start on time so that we are not late. Then we thank you, all of you. I think when you leave our stakeholder, le tla feta mo tafoleng mola ba le fe dijo di preparilwe ke take away. We thank you also Lepeli station, and we thank you the committee coordinators and the researchers and everybody who came here. We thank you. Go and vaccinate. Councillors, come in front. Officials, you must also come in front, please. Come this side. Officials, all of you, you must come this side.